Welcome to today's meeting. I want to begin by recognizing the House Sergeants at Arms that are with us today. Johnny Gilbert is at the back door, Reggie Sills is right here, and Thomas Terry is right over here, and they'll keep everybody in fine shape. We've got a number of presentations that we will move directly into. The first is from Sam Thompson. He is Executive Director, if I'm reading this correctly, with the North Carolina Health Information Exchange Authority, which I think is in the North Carolina Department of Information Technology. And Mr. Thompson, welcome. We look forward to hearing your presentation on how the state is doing or proposes to do as it relates to data collection.
Thanks for having me. Good morning. So I'm here to talk with y'all about, and I'll be representing the team today. Tripp is remote, but we may patch him in for some questions. So I'm here to talk about sort of what we do in the Enterprise Data Office at NCDIT and how it might support some of the work y'all are considering how to accomplish here. What am I doing wrong here, y'all? Let's see. From over here? Oh yeah, there we go. So what do we do at NCDIT? Yeah, we got it. Got it. Me and my colleagues at the Enterprise Data Office work in a number of different capacities managing data for the state. We have a couple where we own the data and a couple where we don't, and I'll run through all those. So we have the Center for Geographic Information and Analysis. Y'all are probably very familiar with their work here. They do mapping on behalf of the state. They've done a lot of work around Helene and mapping various legislative districts, and they manage NC1 Map, which is a public interface where you can pull down geographic, geospatial data and try and understand, how the state is laid out and where different things are happening. So I run the North Carolina Health Information Exchange Authority, and y'all may be familiar with us. We aggregate clinical data from providers across the state and close to real time, claims data from NC Medicaid and the state health plan, other encounter data, and make that. We are an exchange. We make it available to providers in real time so they can make more informed decisions about patient care, and the state can make more informed decisions about the cost and health outcomes of its citizens. And we run the state designated health information exchange, NC Health Connects. Our colleague Tripp, who is on the phone, runs the North Carolina Longitudinal Data System, and they are here to link data across space and time, right? So if you have a request for them, they can join various systems. They're mostly working in the education and workforce space to help you understand and evaluate how those systems are working for the state. Lastly, and we'll be talking about them a bunch today, is the Government Data Analytics Center. And so they are the sort of founding entity within the Enterprise Data Office, and they manage all sorts of data sets. Most importantly for our conversation today, they manage CJ Leads, the Criminal Justice Law Enforcement Automated Data Service. That's a system where law enforcement of all sorts can log in and learn about the offenders they're trying to work with and how best to manage those situations. Also a real-time system. So the mission is there on the screen. We enable a data-driven government by empowering leaders to make informed decisions that improve outcomes for North Carolinians. So how do we do this? How do we go about supporting the state's data needs? We come to a situation like this, or a meeting with our partners, not necessarily governmental, and try to define a need. And then we try to work with them to understand the role we can play in building systems or access or data sets that can help answer that need. Most importantly, we'll be talking about this a lot today. We identify the data owners. There's a lot of legal ins and outs to understanding who can access the data, how we provide it to them, what aspects of the data they can see, and what permissions and agreements we have to execute to make those data available. So then we examine those rules and we apply them as best we can, make the data available to the people that need to make the decisions. We reach that legal agreement to make the data exchange permissible. And then we build the technical or analytic solution needed to start answering the questions that are posed to us. So once we can determine what questions we have, we're here to help navigate the way to the solution, both legal and technical. So we've been approaching from a number of directions about sort of Irina's law / the involuntary commitment situation. Had questions from UNC, had questions from Division of Mental Health, Developmental Disabilities and Substance Use Disorder, and also from the folks in this room. And so we tried to stay relatively neutral about this, but kind of just talk about how data could best supplement the involuntary commitment process. So we borrowed this workflow from the UNC School of Government. I think the person that designed it may be in this room. Shout out to that person. Thank you. This is what we wanted most. How does this whole thing work? What does it look like to do an involuntary commitment? And so we got this beautiful diagram passed along to us by the Division of Mental Health. And I hope we're going to mangle it in a second, but this is it in its full glory with the citation at the bottom. And so we tried to simplify it a little bit, specific to sort of where we think maybe we can help, or at least data can help, and also to sort of patch in Irina's law and where it fits in there. Sort of that Irina's law is that purple box on the left, sort of operating as a fourth entry point. So right now, and our shout out to our colleagues at Division of Mental Health that sort of walked us through how this works. But there's about 4 entry points here. A layperson can submit a petition. A clinician can submit a petition for IVC. There can be an emergency petition for IVC. And now there's an Irina's law entry point where there's more emphasis on judicial referral for clinical review. And so what you're going to see now is sort of our analysis of where data can make this situation potentially more informed. Right? And the first place where we see that is the magistrate reviews the petition. Ostensibly, not necessarily in a systematic way, but that magistrate has access to criminal justice history about the person in question. They do not have access to their clinical history, their medications prescribed, their diagnoses, their recent encounters with the clinical system. And so that's sort of an asymmetrical availability of information. It is important to say here, it's a whole other question what's appropriate for that person to know about that person's medical history. We're not going to get into that today, but that person does not have that information. So the next place where we see a sort of potential for insights and more information making this process work a little better is Irina's law. Obviously, similarly, the referral is coming from the law enforcement side. But again, in these situations, there's asymmetrical information. There's history as far as the criminal justice. There is not history regarding clinical. And obviously, this decision deeply involves both of those sets of information. Next place where we see an imbalance of information is on the opposite side of the scale, right? So we have a clinician examining the individual in question, and they have access ostensibly to their clinical history, right? Hopefully they're using the health information exchange. They're seeing all their encounters across time and their diagnoses, their medications. But they are blind to their criminal justice history, right? Which is an important part of this decision as well. In talking to clinicians about the situation, they have said that history would be helpful in making these decisions. The next place we see an imbalance of information is this sort of, and this one's unique, the transport of the individual, right? So we've had some questions from folks in this room, from folks at DMH about boarding data. So where do we know where we can take this person if they pass through that first gate and it's determined, at least at the first step by a clinician, that they should in fact be strongly considered for involuntary commitment. I think there's a question of where they can be transported to. There's not always beds or places for these people to be taken to while they wait. The second examination, right? So going to the second examination, very similar to the first one, there's an imbalance of information here. They're aware of this person's clinical history. Again, ostensibly, I can't promise you they're using the health information exchange, but it's available to them, as is their EHR. But they don't have access to the criminal justice history and what the implications are there for whether or not that person should be committed. Then we have a couple other sort of unique spaces here, right? And this one comes especially from conversations, again, with clinicians and the folks at DMH, but there's not a systematic way where the documentation in this process is being routed, right? So whether that's the petition or the results of the evaluation, those documents are aggregating at the stops along this route. They're not passing through in a systematic way, in a standardized way that can facilitate evaluation at the back end and good decisions throughout. So, and lastly, right, and I think this is what we've heard most about, I think, from people in this room, because I think this is where the process really is at this point. But the sort of, you would call it evaluation, you would call it continuous quality improvement, there's not answers to these questions about how often is IVC happening, what factors predict IVC happening, how can we improve the IVC process and the associated outcomes, right? So that involves data from throughout this process, as well as analytics and thoughtful questions about how we can make it better. So how might we support this? Again, we're really not trying to engineer a solution here. We're just trying to talk about our systems and how they might be helpful. So talking about the system that me and my team oversee first, we provide close to real-time data, as I mentioned, to clinicians, right? And throughout this process, we can potentially provide clinical data to inform IVC decisions. We're going to talk in a second on the next slide about some regulatory factors that prevent the access to those data. But I think that may be most important, right? The evaluation is important, but the operational process, so sitting there, trying to make a decision, what information is available to me while I'm making that decision, is where I think we can help most. So additionally, when we talk about monitoring and evaluation, we have people's clinical history across providers, across time, going back to 2016. And those data can be used to monitor and evaluate the IVC process. Is it working? How can it work better? To what extent are the boxes being checked and the regulations being followed? Lastly, and I think the HIA in particular is built for this, we can route that petition and examination data throughout the process. We already have tools like direct messaging that's clinically protected and can allow for the exchange of sensitive data. We also can create standardized forms that can pass from clinician to clinician to clinician. They can contain this information in a standardized way and allow for evaluation on the back end. So then, and my colleagues in the room that work on this system, if you all have questions, can help with it. Their system, the Criminal Justice Law Enforcement Automated Data Service, CJ Leads, provides close to real-time criminal justice data similar to the HIE that can inform IVC decisions. And the amount of data in that system is truly broad and impressive, and I believe can be very helpful. Similar to HIE as well, provide historical data to monitor and evaluate involuntary commitment. And then my colleague Tripp, who's on the phone, his system, Longitudinal Data Service, is built to take in that cross-sector data, join it across people, across systems, and provide answers to those cross-sector questions like we're dealing with here. So then what are the regulatory factors that make this harder, right? So the data in my system is HIPAA protected, right? Which means that it can only be accessed by covered entities, so that's providers, health plans, entities like that, and their business associates. So if I have a business associate that's doing analytics or quality improvement for me, I can enter into contract with them and share the clinical data. So then for CJ leads, that CJ is protected. It can only be viewed by law enforcement. And so we've speculated for some of these questions along the route that I looked at before, and we've thought of one role that could really access these data as it currently stands, and that would be something like a jail nurse, right? Someone that is both within a law enforcement setting and also is a covered entity, a HIPAA-protected entity. There are routes around that. I think other roles that could be created or agreements that could be executed. It's the only type of person we could think of now that could operationally access both systems. And lastly, our colleagues at the Longitudinal Data Service are only allowed to access education and workforce data. So if we wanted them to join that clinical data, join with that criminal justice data or whatever other factors that may need to be involved to evaluate this process, they would need additional authority to access both those sets of data. And with that, hopefully I didn't go too long, and I'll take some questions if you have them.
Now, do I understand Dr. Stallings is on the phone so that he can participate?
Yeah, and my colleagues from CJ Leads are here too if you have questions.
I'm wondering if we might want to hear from them before we come back to questions. If Dr. Stallings or someone else on this data piece is ready to go.
Yes, sir. This is Trip Stallings calling in from sunny Atlanta, Georgia. I want to thank Sam, first of all, for covering a large part of the waterfront there. I don't have a lot more to add for you all right now unless you have some specific questions. NCLDS just stands ready to be able to create the necessary cross-sector data sets that the state needs for preparing for policy implementation and also for evaluation of the success of that implementation. As Sam mentioned, right now, we're not currently statutorily authorized to work with a particular data for this question, but that's something that we will be bringing to your attention later this summer at Janner Short Session.
Was there someone else over here that you referenced a moment ago that is available as a
They're available to
or
answer.
they want to say something?
I don't think they have statements, but
Okay.
they're here to answer questions.
Okay, great. Just another little housekeeping matter. If the members of the committee have not turned in their reimbursement form for attending today, if you'll get those to the Sergeant at Arms, please. Questions from members of the committee. Representative Torbett, you're recognized.
Real quick, Mr. Chairman, thank you. Thank you for your comments today. Can you define for me, when you use the term near real time, and what's the definition of your near in that statement?
So I won't speak for CJ Leads, but for the Health Information Exchange, we have transactions with your more sophisticated electronic health record systems that are literally real time. As soon as they complete the clinical note, it pushes to the HIE and surfaces for other providers to see. We have other less sophisticated EHRs that are pushing 2 or 3 times a day. Pharmacies, for example, submit their claims to us. So that's less like a clinical encounter and more like a financial transaction. And we only get those twice a day, and those would surface as soon as they hit our system. So that's why we say near real time rather than real time.
Not a huge time lapse then.
No, no.
Thank you. Thank you, Mr. Chairman.
I will say claims, so we get claims from Medicaid and soon state health plan as well. Those are less frequent. Those are daily.
Other questions from members of the committee. Representative Pirtle.
Thank you, Mr. Chair. Thank you for your presentation, and I do think the data collection is very important. Obviously, different groups along the process of the IVC process would need different parts of the data. From a law enforcement perspective, we started collecting data on IVCs back in 2002, 2003 in my agency, and we continue to collect that. Although the clinical is not as important to us, it's the contact with the consumer when they're in crisis and their tendencies and seeing the outcome of the IVC process is really what was behind our collection. So I do think it's important especially for law enforcement, to know how that contact has been in the past. You know, your past behaviors is needed for future contacts. But I think it also has to be a way that we can ensure that the physicians get this information when they're dealing with the consumer the second, the third, or the fourth time, and make sure that they make the best decision with all the information they can have. And if they don't have the past results of the past contacts, I think that impedes their decision making, and perhaps it would expedite the decision making. So I do think it's important, but I think that not everybody needs the same information from all the data collected. It should be based on need, and it's going to be interesting to see how that turns out.
100%. I think privacy, security is our first concern, right? That's why we have that long process to make sure that all the rules are followed and that everybody's privacy is respected and people see exactly how much they need to see. But totally agree. When we read the IRENA's law, our understanding is that both sets of data need to be strongly considered in the decision, particularly on the clinical side as it relates to law enforcement data. But the amount any given person needs to see throughout the process absolutely should be appropriately managed.
And Sam, do you mind if I interject something else too?
Yeah, go.
I think the other thing to keep in mind is that whatever solution our various teams are able to put together, one of the things we keep in mind is we have one framing for this, which we call role-based access to data. So this is to the committee members' point, is that once we know what the questions are and who needs to see what, all of that is typically governed by definitions of specific roles and people attached to specific roles, which helps to ensure that the folks who need to see certain pieces of data see those data and not everything that's in the full data basket.
Dr. Reeder.
Thanks very much for the presentation and for coming today. Question about the clinical encounters. Are all mental health treatment facilities and individuals and substance use included in that, including the state facilities?
No, that's a really important question. The state-operated healthcare facilities are in there. We just went live. As y'all may know, they just transitioned to an Epic system. Yeah, I probably know because you funded it. And we have gone live with that Epic system already. They are submitting admission and discharge transfers to us in real time. We know that's really important to the people managing services for those very complex patients. But to your question, Representative Reeder, no. Right now, the Health Information Exchange Authority does not accept substance use disorder treatment data. Those data are treated with a higher level of security based on a federal law, 42 CFR Part 2. And where the data that pass through us right now can be exchanged with what we would call an opt-out model. So a patient can tell us, don't keep my information in the HIE, and we'll remove it. We won't surface it. You can't see it. We don't do a consent-oriented and opt-in model. You have to do an opt-in model to exchange Part 2 data, substance use disorder treatment data. We would like to change that. It is certainly possible. There are other health information exchanges in the country that do it. But it would take developing that consent model and developing the appropriate protections to make sure that data was used by, as Tripp said, by the appropriate roles and the appropriate people, and it can't just be opened up to everyone. It's on our roadmap.
So follow-up. So a private psychiatric facility right now, Holly Hill, would not be contributing to the HIE for mental health?
No, they are. It would be, we draw the line right at that substance use disorder treatment. And that's even a slightly nuanced line. So we can know someone has a substance use disorder. We can know that they got that diagnosis if it was at a primary care or a hospital. We just can't know when it moves to a facility that receives SAMHSA funding, what occurred there, what exact services were provided.
All right. One other question. We went to e-courts across the state. Is that part of the enterprise data organization and trying to capture data from the e-court system that might be beneficial for our conversations?
Yes, I do know that eCourts is a data source, but beyond that, I would defer to my colleagues that represent CJ Leads. You want to come up, Vinay?
Good morning, Representative. This is Vinay Kanchatla. I manage criminal justice portfolio. Our primary application is CJ Leads. We integrate data from many sources, and one is AOC, and we have fully integrated all the 100 counties of eCourts migration into CJ Leads. And for this purpose, yes, that will be our potential data source. Thank you.
Representative Green.
Yes, sir. Thank you, Mr. Chairman, and thank you, gentlemen, for your presentation. Just one quick question for information that, for me, it's not familiar with the Health Information Exchange. I just wondered, is there any information from other states that can be tracked through that exchange? If somebody had prior contact in Virginia or South Carolina, would that?
Yes, absolutely. And I think this was particularly useful. We saw high usage during Helene when people were displaced to other states and people from other states were displaced here. We participate in a national exchange, eHealth exchange, where we can be queried by other HIEs and even other EHR systems in other states, and we can do likewise to them.
All right. Thank you.
I don't see any other committee members at this point. Question. I have several questions, if I may. On the Health Information Exchange, is that the same system that relies upon what I'm going to call the electronic medical records? And are you saying that that is fully in place now at all of our state psychiatric hospitals and state facilities, where it has not been until, if it is, just recently?
Yes, that's my understanding. I don't know exactly when. I won't speak with what they had before they had their new Epic instance, which is a sort of is the top of the line EHR, but they have gone live with that, and we are connected to it now.
And the information that's coming into you is coming not from all state facilities as well as from private providers?
Both.
Okay.
But to be clear, though, not everyone's connected yet. Entities that serve Medicaid, so they take Medicaid dollars or they take state health plan dollars, they are required to connect. But there's a queue. Not every single one is connected yet, but the vast majority are represented in the system, particularly patients, because the larger systems are already connected.
Yeah. In talking about the higher level of security that was required, I think, for substance abuse, to what extent is that federal and to what extent is it state? And I think you made reference to the possibility that we could address that statutorily, maybe. Can you expound on that?
Yeah, so the law that regulates the exchange of substance use disorder treatment data, 42 CFR Part 2, is federal. And it says you have to collect that consent. It has to be stored in a separate system, right? It can't be stored next to your other sort of standard clinical data. And the state comes in with the Health Information Exchange Act that established our my unit, which in that says you cannot submit 42 CFR Part 2 data to the HIE. That's more of a preventative measure, because if we were to receive it, we don't have a system set up to handle it, so we have to warn providers away from it. I'll say just briefly, that has a cooling effect on all behavioral health data submitted to us, because if a smaller behavioral health provider is like, I don't know if this is Part 2 or not Part 2, they're going to tend to the safe side and just not submit it. It can be done. We have actually strategic plans mapping out how it would be implemented. We would have to roll out a consent-based tool in the system, or an attestation tool where a provider could say, yes, this patient attested that their data can be exchanged. Or the patient does, they could go in and attest it, or Medicaid could consent them at the time of enrollment, state health plan could consent them at the time of enrollment. All these things could happen together. And then we could start ingesting the data, we could store it in a separate system, and we can make it available to the appropriate providers via the HIE. So yes, it can be done. It would take some funding. It would take a little time. It would take collaboration with our attorneys, but we have a map to do it, yes.
It sounds to me like it's a big gap in the system if we are not able to look at information about substance abuse and its relationship to patients who may be experiencing involuntary commitments.
Yeah,
Maybe should be.
I agree completely. I would say, moreover, behavioral health, intellectual developmental disabilities, this is where the HIA is most useful. These are very complex patients that are receiving care for their physical health and their mental health, and they have care managers, right, that are trying to weave that whole story together and try and keep those people, manage their costs, manage their health outcomes. And if they don't, they have gaps in that information around people's relationship to substances. They can't do an effective job. So I totally agree. It is a big gap in our system.
In your presentation, you made reference to, I think, the analytics aspect of what you all do. Is there a process by which legislators or the legislature submits a request to your organization for you to get back to us with some type of analysis of something?
Yes, so typically HIE is not getting a request from the legislature. We're getting requests from other state agencies, very frequently DHHS or partners in the private sector or local government. TRIP system, Longitudinal Data Service, is set up for that kind of work. And TRIP, I don't know if you want to jump in with help me.
Yeah, there's a couple of things. So the first is there's a general project intake procedure for all of the Enterprise Data Office where we receive the question and or the need and figure out which teams are best suited for addressing the question. Not all questions are analytical in nature, so we want to take that first step to say, where does this belong? If it turns out to be a longitudinal data question where we need to pull together data from various sources to make available for analytics or evaluation or research, that's the kind of thing that NCLDS is well positioned to be able to do technologically. So there are a number of different ways for members of the legislature to reach out to us and let the Enterprise Data Office know what your specific need is so that we can put it in front of the right teams.
During your presentation, you referred to data owners that you have to deal with. That would be inclusive of private as well as state. Is the system's intake of information or data limited by the refusal of certain data owners to participate?
Yes. So it's I'd say 2 levels for my system, and then I'll allow my colleagues to jump in. The HIE technically owns the data in our system, right, once it's submitted. However, we're beholden to our partners, large university hospital systems down to small independent primary cares, and if they feel we're misusing their data, they can make the decision to stop submitting. We don't have the hammer to enforce them to submit if they don't feel comfortable. Then that said, there are entities that are dragging their feet about connecting, even though they're mandated to do so, or there are entities that operate by the letter of the law and just submit their Medicaid patients and their state health plan patients and don't submit all their commercial patients, which we hear from other providers in other parts, really in the same parts of the state. Hey, I'm not seeing everything, right? I'm not getting the whole story on my patient when I query your system. And we say, well, it's hospital X has decided not to submit their commercial patients. There's only one big system, I'm not going to name who it is, that has made that decision, but some smaller providers make that same decision.
So sounds to me like we have the problem of substance abuse and the federal law, and so we're not getting that data into the system the way it might be helpful. We've got private data owners that are dragging their feet, refusing to participate, participating partially, so we're missing data there. We've got state agencies that are sort of in a similar posture, that they don't like what we're doing with it, or are upset about or concerned about this, that, and the other. So it sounds like we've got a lot of gaps yet in who we get data from. We could theoretically be getting it from everybody, but we're not.
That's true. I would reiterate that the vast majority of North Carolinians are in the system, and the vast majority of their encounters are in the system. But yes, and you know, without stepping too far into it, there could be stronger enforcement mechanisms for connecting. Right now, we're largely toothless. There was financial penalties for providers that didn't connect. But we have rolled those back at the behest of our partners at DHHS. I will say, as it relates to state entities, we have nothing but willingness. They're submitting their clinical data. I have nobody to point at and say they're not being willing.
In the non-health data space, I think the greatest challenge a lot of the state agencies face is something Sam mentioned throughout the presentation. That is how to navigate the very intricate and challenging federal policies that govern what data can and can't be shared. So a lot of times it does take a while to sort that out, and that can feel like obfuscation or an attempt to block, but frequently it's about making sure that we are dotting our I's and crossing our T's, and it takes a while to navigate through how to work within those rules.
I'm on a roll. On your sheet that says what could inhibit using data to inform the IVC process, once we get what data we get, it can only be accessed by, it says, covered entities and their business associates. Can you tell me what covered entities are and what are business associates?
So covered entities, this HIPAA language, are entities that are either helping with healthcare treatment or healthcare payment and operations. So typically, we think of those as healthcare providers, payers, healthcare clearinghouses, which are typically entities helping with analytics or claims payment processes. Those would be your standard covered entities. And then a covered entity can enter into a business associate agreement and say, hey, you're going to provide care management on my behalf, or you're going to do analytics on my behalf, and therefore I can pass you my data and you can work with it legally. And that's yeah.
Is there any room for state statutory action to expand covered entities or business associates either beyond those categories?
I'm not an attorney, so I'd be reluctant to speak to that. But I will say that HIPAA is a pretty flexible law, and there's a lot of ways you can work within it to find those kind of exceptions. In my opinion, it is built more for figuring out how healthcare data can be shared safely and securely, rather than to prevent healthcare data from being shared safely and securely.
Regarding CJ leads, you say it can only be accessed by authorized law enforcement covered entities. Is that a state statutory provision, or is that, again, involving federal law?
Largely, it is a state enforcement.
So we theoretically could modify that.
Yes, sir.
Maybe a final question. Regarding the longitudinal data system, it says it's currently authorized to access only education and workforce data. Again, do I assume correctly that state statutory limitation and that we could theoretically expand it?
That is correct, sir.
Okay. Representative Carson Smith.
Thank you. Just to follow up on the health information exchange, if an entity doesn't provide the data that they are supposed to provide, or they're withholding some, can they be prohibited from accessing the exchange itself? Would that be Could that be a little teeth?
That's how it works, by and large. So if we have a participation agreement with your practice, then that day that it's executed, you can go into our clinical portal or get clinical notifications right away, right? Because you're participating in good faith. We just haven't been able to make the technical connection yet. If you don't, and then once you're live in production, then your data is pushing in, and all the other providers can access your data. If you don't have that participation agreement, you are locked out of the system. We also have what's called a participation, a submit-only agreement. Those are entities that have said in advance, I'm going to do the letter of the law. I'm just going to give you state health plan and Medicaid data, and I don't care about accessing the system at all. And we do have some of those that are less and less frequent, and people are often changing over from submit-only to a full participation agreement.
Representative Pirtle.
Thank you, Mr. Chair. You know, at the end of the day, the data that we're trying to collect, and I'm not sure we don't not spending more time trying to figure out how to collect the data than what we really need to, because at the end of the day, the data we're trying to collect is to make sure that law enforcement officers, when they have contact with a consumer, does it in the safest way based on past contacts, and that the clinicians have the most information to make the best decision for that particular consumer so that they don't go back in crisis. And to me, it just seems that we're talking about how do we collect this data when realistically you're talking about the record management system for the hospitals, whether it's Epic or private provider or a hospital that uses maybe some other type of record management system, AOC, and the record management system for law enforcement. And there's data there. It's just a matter of getting it together. And CJ Leads is a great thing, but it's more of a criminal aspect to it than a civil aspect, and that's what we're talking about right here. We're in the civil area and not so much the criminal. These consumers aren't criminals; they are folks that are in crisis and they need our assistance. And so, to me, sitting and listening, I think there's some we making it much more difficult than it needs to be. Thank you, Mr. Chair.
Other questions from members of the committee? Seeing none, Ms. Thompson, Dr. Stallings, thank you very much. We appreciate it. Thank you, Doctor.
Thank you.
Moving right along, our next presentations are from LME MCO's perspective on the mobile crisis teams. I think we have two presenters, if I'm reading my cheat sheet correctly. Allison Gazda, Chief of Clinical Services with Partners Health Management, and Sean Schreiber, Executive Vice President and Chief Innovation and Strategy Officer for Alliance Health.
Sean Schreiber, thank you for the opportunity to speak today. I work for Alliance Health. We are one of the LME MCOs, one of the four that comprises the North Carolina Association of Public and Community Health Plans. Also, before we get started with our comments, I want to thank this organization for tackling and challenging the really complex issue of public safety at the intersection of behavioral health and appropriate behavioral health crisis care. As everyone's learning, this is quite complicated as you're looking to implement a new law across the state. We also appreciate the opportunity to be at the table this morning for this discussion. The LME MCOs play what we think is a unique role in the North Carolina healthcare ecosystem. We are right now charged with managing the Medicaid services for some of the most complex individuals in the Medicaid system. To be managed by an LME MCO, it means you have to have a serious and persistent mental illness, pretty significant substance use disorder, or intellectual developmental disability. We're also charged with using dollars that are given to us by this body to provide services for the uninsured and underinsured. In this role, for the last several years, we've been building out crisis and additional services across the state. While our systems are not perfect, and certainly there's challenges in navigating these systems have helped divert thousands of citizens from emergency departments, jails, help those individuals get linked with crisis services. So today we're going to talk to you a bit about mobile crisis services. I'm going to provide just a brief overview of how they work today. My colleague Allison Gosda will talk a little bit about how we think mobile crisis could play a role in your implementation of IRENA's law. And there were some questions from, I believe, a previous proposal on outpatient commitment and different roles for mobile crisis in the outpatient commitment process, and we'll spend a little time speaking through that. Sorry, which should have gotten coached on this first.
It's okay.
Thank you.
Let's see if it's working. Do this. Use the space bar for now.
Okay.
You can just. Okay. Great. We apologize. We're going to get someone from
Okay.
ISD. If you don't mind, would you like to put us at rest for 5 minutes or so? The presentation is not working, so we're going to get someone from ISD.
We're on break for 5 minutes. Technology. Technology.
This is a great follow-up to a technology conversation. So.
Apologies.
That's okay.
We've never had this happen before.
Let's resume our meeting. I think we've got our technology working for us now. I'll give you a minute or two to resume your seats. Mr. Schreiber, you're up again.
Thank you, sir. So let me spend just a few minutes to talk about the initial design and what Mobile Crisis is intended to do. And I should add that Mobile Crisis would be considered a covered entity, and they are able to access the information on the health exchange to help in their assessment work. So really the goal of a Mobile Crisis team is to provide 24/7 response to behavioral health crisis in the community. The goal is for an individual to be deployed, ideally a team when possible, to go into a community setting. On their own, it could be part of a co-response to meet with individuals, experience a crisis, do an assessment and evaluation of the individual's need, make some determination of their need for care. If they believe just additional time with this individual can take away the crisis, sit and continue to do crisis de-escalation and make sure they're kind of safe, link the individual at the next level of care they may need within the community. There are times when Mobile Crisis will go out and the person may appear to need an involuntary commitment, and they can start the commitment process described through one of the pathways. Or there could be occasions where the person does not meet criteria for commitment, but the person is willing to go to get treatment and requires some kind of facility-based care. Mobile Crisis can arrange that care. The goal of this service primarily is to divert individuals from higher cost and more crowded systems, or systems that are really not the best place for individuals with a mental health crisis to be, such as jails and detention. So again, the goal is to do these assessments and get linked to the next form of treatment. The way the system typically works, there's multiple ways individuals can get referred. An individual may call the new 988 behavioral health line. All the Medicaid plans in North Carolina, the standard and tailored plans, have to have a behavioral health crisis line. Someone could call those crisis lines and Mobile Crisis can be engaged. Or if people are aware of who the Mobile Crisis provider is in their community, they can call Mobile Crisis. The team responds, does a stabilization hopefully, and then arranges for follow-up care. It is just one of the tools in the system that's meant to address individuals' experience of behavioral health crisis. There are some constraints. There are some constraints to the service. It is considered a safety net service funded by, again, the health plans, the Medicaid health plans in the states and LME MCOs. Today, all Medicaid plans cover Mobile Crisis. As LME MCO system, we cover the service for individuals who are underinsured or uninsured. However, commercial insurance and Medicare do not pay for this service, which creates a funding gap. Additionally, the team it's supposed to be a team-based service, but the way it works kind of in the real world and in practice is there's one individual on the team who goes out into the community, meets with a member. They have a support from potentially a licensed clinician who's in some other setting. An IVC, as you're aware, is required. A first evaluation for an IVC requires that the individual either be a psychiatrist or a psychologist or MD, or they can be a licensed behavioral health clinician who's received additional training from the state to be considered a first examiner. So for Mobile Crisis to work in the context of Irina's law, there would have to be some changes, not within the statute, the structure of the team, in the practice of the team, and making sure there's licensed clinicians available to go out and do those assessments. Again, not every response or most responses are not being done by a licensed clinician today. It's a crisis clinician trained in mobile response. And again, the service must be provided 24/7 to anyone in the community, regardless of their insurance coverage. This does create workforce pressure because it creates a wider swath of individuals that have to be treated than the typical kind of publicly funded behavioral health providers would be treating on their own. So these factors would influence how Mobile Crisis could be used. So in essence, Mobile Crisis, to do a general basic first evaluation, is probably not the ideal service. However, in the context of Irina's law, we believe there are adaptations that could be made, and my colleague Allison Gazda will speak a little bit more about that, and then she'll provide additional context on the outpatient commitment rules where there were questions from a previous presentation. Thank you.
Thank you, Sean. Good morning, everyone. I'm Allison Gosda with Partners Health Management. So, let me get the slide. So Sean shared a little bit about mobile crisis and the implications of using mobile crisis for first level evaluations with IVC, and talking a little bit about how mobile crisis may not be the most practical solution and that is due to the limitation of the licensed clinicians in order to do that first evaluation. Other implications are also, so we've got the licensed examiners having secure evaluation locations. And I know that we've talked about, doing those evaluations in jails, which would be a secure location. And that is important to have those secure locations to keep individual and the staff safe that are doing those evaluations. And finally, the third support that would be needed that I think we all could agree on is a coordinated system, particularly establishing dedicated timelines, when somebody would be evaluated, how soon that would be done, and then ensuring processes like warm handoffs, communication between your law enforcement, your emergency management services, your emergency department or hospitals, and the LME MCOs who often dispatch mobile crisis to the communities. And another important thing is the appropriate follow-up care. These are all things that need to be considered. So mobile crisis can certainly be a part of the solution with the right staffing, in the right spaces, in the coordinated system. So some things to consider for first level evaluation under IRENA's law would be the infrastructure. So we talked a little bit about, having the licensed clinicians, but particularly with those safe, secure locations are very important. The other piece would be state hospital capacity. So what happens when somebody does meet involuntary commitment? If right now there's limited capacity in our state hospitals, which then backlogs our emergency departments and slows down the response time for somebody getting to the care that they need and that they deserve. The workforce, we talked about that. So it's very important that we invest to recruit and retain licensed state certified examiners. And that would be whether that's through mobile crisis or other licensed clinicians throughout the state. In order to do that. And then the system coordination. So again, defining those evaluation timelines. How soon would someone need to be evaluated, for that first level evaluation? What would be the expected time frame for a mobile crisis or another licensed certified examiner to get there to do that evaluation? You want to make sure those are done timely. Again, you don't want to prevent and slow the process. You don't want to backlog things. And then another important piece would be what care linkage is going to occur for individuals who may not meet IVC criteria but still need services. I think it's that follow-up and that coordination of care that's also important that we need to consider. So I'm going to shift, since you all are interested in outpatient commitment and mobile crisis. And again, mobile crisis can play a role with outpatient commitment, but it is definitely not a standalone solution. It can support mobile crisis. For example, if someone needs a well-being check in the community, somebody's not sure about them, law enforcement typically will go out, but mobile crisis could go with them to check on an individual. How are they doing? If they're on an outpatient commitment, they haven't shown up at a provider, but you want to check to see how they're doing, they can certainly do that. But mobile crisis is not designed to provide ongoing monitoring or that long-term care and support that is often needed for people on an outpatient commitment, because we're really focusing on that long-term treatment adherence. So I think relying on mobile crisis would not address the existing gaps in the continuity of care for long-term support. And we also know that outpatient commitment itself has operational challenges. The current process lacks the infrastructure and coordination and resources that are needed to function consistently and effectively across the continuum of care. I think it's also important to note that with outpatient commitment, it also requires a coordinated and structured system. And I do believe the LME MCOs are ready to be partners with the department as well as the legislator to make some commitments and changes to the system and the workflows that are needed. And I'm happy to talk a little bit about, this is not on a slide, so my colleague Sean kind of gave me a heads up that you might want to hear a little bit of a comparison between outpatient commitment and assisted outpatient treatment. That is the New York model. So let me talk just briefly about some differences there. So both outpatient commitment and assisted outpatient treatment combine judicial oversight along with, and so outpatient treatment then also adds an intensive care management component to the treatment. It's both have a clinical evaluation that are involved, both have judicial hearing and due process, and they're both court-ordered outpatient treatment. Where assisted outpatient treatment kind of adds to or maybe augments the process is that there is dedicated care management. There's frequent follow-up and reporting that is done. And there's a structured response to missed appointments and crises. And I think those are the things that we're currently missing in today's process. Also, some additional differences would be the length of time someone might be involved with assisted outpatient treatment versus on an outpatient commitment. Here, it could be 90 days. It could be renewed after 90 days. In New York, sometimes it's a minimum of 6 months or 12 months. So those are just some things to think about. And also, when you talk about trying to get folks involved in their treatment, decreasing that kind of experience with forced coercion is very important, right? And so how do we do that and try to engage them in their own treatment? And that is an important thing. I'm going to leave you with this. And maybe we could be back, invited back to give a little bit more presentation on assisted outpatient treatment and what that might look like. But we know that assisted outpatient treatment works. You've heard about the New York model. We actually had a pilot in North Carolina in 2020 to 2023. And that pilot was in Burke County, Catawba County, Cleveland County, Gaston County, Iredell, and Lincoln counties. May not have heard of it. It was a SAMHSA-funded pilot program. And I just want to share and leave you with some outcomes for the individuals. There was about 98 individuals who were involved with that assisted outpatient treatment pilot program. 87% of them engaged with their care managers. 85% of the individuals reported that it was an impactful experience for them. 87% actively worked towards their recovery. And 100% of them said that they felt a decrease in the experience of forced coercion and an increase with procedural justice. So I think that's some pretty remarkable outcomes that we had right here in North Carolina a few years ago. Thank you very much for the time this morning.
Questions from members of the committee?
Mr. Chairman.
Representative Torbett, I'll come in. Representative Torbett.
Yeah, thanks. I just was noticing on the bullet point about the operational challenges of outpatient commitment, and that's exactly why we're here. And I hear a little bit of concern of the way we're currently operating is doing. Y'all are doing yeoman's work. I won't shy from that, but we need to do so much better. And that's why, like I say, the committee was formed, and thanks to the chairs for doing that. But we need your help to get us there and to convince people like myself and colleagues here that if it requires additional space, if it requires additional beds, then it requires additional funding, and it is a priority. If it's not for the safety of our and well-being of our citizens, what else is there? So help us reach those goals of attainment and make sure that people that can work within society to keep themselves safe with no harm to others are allowed to do that, absolutely. But those that just might be on the fringe or might be considering causing harm to themselves or others are not left to wander around in society. We need to try to get those folks help, and thank you for work that you do.
I think Representative Morey got my attention first. Come back to you.
Thank you. Thank you for your presentation. How many mobile crisis teams are out there, do you know, in the state? About?
There's one for every county, but there may be one team that covers across counties.
Okay.
Like we have we have one mobile crisis provider that covers Gaston, Cleveland, Lincoln. We have another Burke, Catawba. That's just an example, so.
Great. Thank you. And just one follow-up, and I think we've heard it many times that there is such a shortage of the licensed evaluators. And if there were more and they could be a part of the mobile crisis team, do you think that would help serve a lot of the people that are in need of emergency help?
I can start and you can jump in. So I think that's an important piece. So that's why you can have licensed clinicians who are also certified examiners that are not part of the mobile crisis. And, setting up a system and processes that could then draw upon that pool of licensed clinicians, I think would be a better option than having everybody involved with mobile crisis. So I think it depends on the community's needs. Mm-hmm.
Representative Pirtle.
Thank you, Mr. Chair. Thank you for your presentation. Obviously, I'm a big fan of mobile crisis with a background in law enforcement. But years ago, when mobile crisis first really became involved in our county, one of the questions I asked at a meeting kind of like this with all the providers was, we often have issues where a consumer will meet the criteria for inpatient treatment, be transported to a state facility for their treatment, and then on their discharge and they're transported back home, they're given just enough medication to get them through their next appointment for their outpatient follow-up. And often that doesn't occur. They go back into crisis and the process starts all over. And I asked the question, why would mobile crisis not be able to respond to make sure that soft handoff occurred to ensure that there was a continuation of care? And I was told back then, many years ago, that it didn't meet the service definition of what mobile crisis responsibilities are. And my question now is, have those service definitions changed to the point that, sometimes you have to do things that's outside the box, so to speak, to ensure that the consumer is taken care of? Are we doing anything to ensure, is mobile crisis doing anything to ensure that soft handoffs occur from the inpatient to the outpatient treatment of those consumers so that we don't send them home with just enough medication not to make the follow-up appointment? Thank you, Mr. Chair.
Thank you for the question. So I can't speak broadly, but I can speak for at least my region, and Allison can speak with hers. We have not asked mobile crisis to do that so we can preserve mobile crisis for the front end work. However, we've contracted with other teams, and we call them bridging teams, who can meet with individuals while they're in the hospital to do that, get the relationship and do a warm handoff. We've found that to be an effective use of peers, and there's a much bigger workforce of peer supports in the state than there might be of licensed clinicians. So I think the issue is not mobile crisis, but is there a system and service in place that can do those handoffs? And that really should be incumbent on I think it's something that LME MCOs do arrange, because we actually get measured on how well people do follow up with care. There's a national measure on that, as health plans will get compared on. So beyond the fact it's the right thing to do, it's better for the person, it cuts down on expensive readmissions, it's how we get judged on kind of a national benchmarking measure. It's really important, and I believe all of us have different structures and system. Part of the state's care management system includes those responsibilities as well. I'd add to that, one of the things that we've all built, and thanks also to this body for some of the funding that's been provided, the urgent cares sometimes serve that role for us. It's really common with our population for them to not show up to their appointments, almost at 60%. And it creates actually a big clinician issue, because we talk about workforce, but you have clinicians sitting there not working because people aren't getting there. And so we work through that. The urgent cares that we set up have the ability, if someone misses that appointment, not to have to wait. Could take 3 more months to get into a psychiatrist, to get medication and get bridged. So there are things that work in this system. I think the challenge is always making sure they're coordinated, knowing when someone's missed an appointment and helping them get that. I think too often we're finding out after things have gone wrong, and we certainly need to be more proactive.
Representative White.
Thank you, Mr. Speaker. Mr. Chair, Ms. Gosda, did you say that there was a SAMHSA model that you all had done? And if so, could you get that to us, the results of that? And would you tell me which counties you said? I know Iredell was one.
Yes. So Partners did have that SAMHSA grant, and we did pilot that in, let me get back to my notes, and I can tell you exactly. It was in Burke, Catawba, Cleveland, Gaston, Iredell, and Lincoln counties.
Thank you.
And if you tell me where to send the evaluation summary, I can get that to you. Thank you.
If you could provide that to the committee staff, then we can share it with folks.
Absolutely.
Yeah. Okay. Dr. Reeder.
Thanks very much for your presentation, and I like the fact that you want to be a part of the solution, so that's really helpful. Right now, when you said that Medicaid will pay for some of these evaluations and pay for mobile crisis, but the commercial plans and Medicare do not, is there like a billing code that happens when a mobile crisis person comes out to do that evaluation? And is that billing code based on some complexity of the patient, or is it a standard code? And if you give me a ballpark of what that might be, then I'll have a follow-up.
Sure, I can start. So there is a particular billing code. So individuals will, if it's someone, I can't remember the code, but it's billed in, it's not billed on a level of complexity, it's time-based. So for every 15 minutes you're there with a response, you bill an additional unit of care, but it is billed that way.
And so then the question becomes, from the business plan, right, with the mobile crisis, someone comes out, is it not licensed? It's the same bill if it's the non-licensed person who shows up, the time-based thing?
That's correct. It's the same.
Should we consider, as we're going through this, some enhanced rate for a licensed person who could be that first responder who could perform that? And is that needed? And do we have that authority within the state to create that code? And then the follow-up is, can we require all providers, commercial insurance, to pay for that?
Well, I cannot speak about forcing commercial insurance to pay for that. That would be great. But yes, we can absolutely, and we do that frequently, that we tier rates both for individuals who are receiving state funds as well as Medicaid for different services. So that would most likely have to be the incentive that we would need to do to recruit and retain additional licensed clinicians.
I would just add the one, I think maybe even some of the just broader funding challenge is just that it has to operate on a firehouse model. And so that's always a little bit of a challenge. You could have a day, believe it or not, where there's just not a crisis in the community, but those folks have to be there and ready. So that just adds a little bit to the cost of service delivery.
I have a few questions, if I may. Just to clarify, in a situation in which the mobile crisis unit goes out, does its thing with an individual, but that individual does not end up becoming involved in the mental health system per se, or in an involuntary commitment. And then some weeks later, let's say, that same individual gets involved with somebody who's doing an eval to determine if they should be involuntarily committed. But it's not a mobile crisis unit that's responding, it's someone else. Is the data related to the mobile crisis team's engagement with that person a few weeks earlier going to be in the data system that's available to the, I guess it's clinician, who is evaluating that same person several weeks later, but in a different context?
So what I'd say is, because these are Medicaid providers, they are required to report their encounter data to the health exchange information, which you heard the presentation about. These providers tend to be small and bill quickly, and so those claims do go to that system. And if the person who's evaluating that has a system where they're pulling that information or checks that, health exchange, they could see that an evaluation was completed. I don't know the full detail of what they see about what happened at the evaluation, but they should know, hey, this person was at least seen a couple weeks ago, and that data should be available.
But that's because a claim was filed for somebody to get some money, not because we're sharing information about the individual's condition that might be relevant to the second determination.
Well, I will just say, because of our role in the system, I don't kind of look into the data. I don't know if you've seen, but we could certainly come as a file. What does a clinician see when they get information from the health exchange? We get claims information. We send claims information. We're different as a non-healthcare provider.
Well, and I'll just add that typically a clinician, so when care managers go in to look in the HIE for clinical information, the reason the claim is important is because usually if you're doing an assessment, you bill for that. So your clinical assessment goes in at the same time as the claim. So I think that's probably
To justify the payment.
correct. Yeah.
I think, Ms. Gosda, you talked about implications under Arena's law, and you talked about supports needed, licensed examiners, secure evaluation locations, coordinated crisis system workflows. What's preventing LME MCOs from acquiring these supports currently? Do we statutorily or regulatorily, that's a word, prevent you guys from doing this? Or are you making choices with the money you get to do other things and you don't have money left for this? Or help me understand, how do we solve the support needed issue? Is it a money problem? Is it a problem of you all choosing to do it and to work together to get it done?
I believe it's probably both. It's not an either or, it's a both. So just as your co-chair, Representative Reeder said, if we were to pay for licensed clinicians to do more, the certified evaluations or be part of mobile crisis, that's going to increase the cost. And we're going to have to pay for licensed clinicians to do this work. So yes, that's going to cost. If we do, and I didn't mention this, but if first evaluations are done in the jails, Medicaid does not cover services provided in jails. So we would have to then default to using our state funding to provide services, to cover those services. So that's where then it speaks to your second point is you're taking money from one pot and moving it over here because it's it's one pot of money. So yes, then it becomes a priority of where do we spend that dollars?
What about the aspect that calls for coordinated crisis system workflows? Is that another funding issue, or is that something for you guys to work out?
I think that it was in the context of this law. If someone's been arrested for a violent crime and they need one of these evaluations, what's the expected time frame, where they conducted, who calls to get it arranged? I think those are the things where the parties would work together. I'm assuming it would be since we don't know exactly where these people are going to get their evaluations yet, but if it was in a jail, we'd have to have protocol between the jails and the mobile crisis teams. And if the LME MCOs have a coordinating role in ourselves, and we do that with some services today where we do have these coordinations. For instance, people who might be in jail who get medication-assisted treatment for opioid use and are getting out, we need to help coordinate. So it's working out protocols and workflows.
So that's something you guys can do that we don't have to tell you to do.
That's right.
Good.
Yes.
You also talked about first-level evaluation considerations, and you mentioned workforce and funding. And it says here, investment to recruit and retain licensed state-certified examiners. And somewhere someone talked about, it's the same page on the infrastructure, state hospital bed capacity. We've got beds. We don't have staff, is what I'm told. Do you guys, being in the business that you're in, have any suggestions to offer us on how we fix our staffing issues? Is it entirely a salaries issue? We got plenty of people out there waiting to do this within a very short period of time if we just pay enough?
That'd probably be a little bit getting out of my area of expertise. I will say that we had worked with an entity that provides hospital care in states where they've supplemented what's happening in the state hospitals. And I believe a proposal was submitted to potentially a senator in North Carolina to understand how that might go. We could certainly surface that report and share with this committee.
It's probably in Senate rules. Can I say that? Strike that.
So much for working together.
One last question. This is, I think, on your last slide. The current outpatient commitment process presents operational challenges and would likely require structural changes to the system to function effectively. I'm not sure that I have understood from what you've told me, if you've told us, what are the structural changes that may be required?
Well, I did say it in a sentence where I said, could we come back and give you a more thorough proposal? Because I believe that would require us. Right now, it's that between outpatient commitment and assisted outpatient treatment, the differences are that there is no care management, there's no, intense tracking, follow-up, those supports, and those are structural, operational things that I believe would need to be in place. But I think collectively, we would like to put together a full, proposal of what that would look like.
Representative Torbett.
Thank you, Mr. Chairman. You bring up an excellent point about perhaps shortages of people to perform functions. If you guys today needed 100 people in a location to perform a needed function, what would be your first thing to do to entice or attract people to come fill those positions?
It's a great question. One of the things we're starting to look more into are these virtual models of care. I think we're a little behind in using some. There are models where people are doing some of these things virtually where possible, virtual urgent care, virtual visits. Some of the providers are getting better, and we leverage those providers in the state where they have broader staff. They kind of put them more in a command center and offer services via telehealth to different kind of satellite locations in the state. There's a particular provider in the state, Daymark, that does that particularly well for crisis services. We also recruit, and times we've paid for providers to set up shop, do some of the infrastructure costs, to pay for some of the startup and ramp up costs while they're building services. It's not a magic bullet, but there's multiple approaches that we would begin to try, and also where possible, leverage some of the workforce. Like peer support and things like that could do some of the work, some of the coordination in the system, and really keeping licensed clinicians, like you hear in hospitals say all the time, having doctors, the licensed people, really only do the functions they can do and not others can do. That would be some of our approach.
Thank you. Huge support of peer support. Thanks.
Mr. Schreiber and Ms. Gazda, thank you both for being here today. We may invite you back another time.
Thank you.
Appreciate it.
Our next presentation is the intersection of guardianship, involuntary commitment, and capacity to proceed. And that's all going to be explained to us by Meredith Smith and Mark Botts from the UNC School of Government and Shay Denning from the James E. Holzhauser, he's the James E. Holzhauser, or she, Distinguished Professor and Director of the North Carolina Judicial College at UNC School of Government. Hi.
How are you?
I'm good. Hope you are.
Nice to see everyone. My name is Meredith Smith. I'm a faculty member at the School of Government. I'm joined, as was mentioned, by my colleagues Mark Botts and Shay Denning. We're here to talk to you today about three different proceedings that have, quite frankly, three different purposes. Shay's going to talk to you a little bit about capacity to proceed, Mark about involuntary commitment, and I'm charged with talking to you about guardianship proceedings. Although these are three different proceedings, they often, one person with severe and persistent mental illness may intersect with all three. So we wanted to kind of start from that perspective. So we've kind of designed this presentation around a case study. This is something that was surfaced from the field. It is obviously anonymized, but is a real world example. So the case that we have involves Paula. She's a 36-year-old woman who is living in the community. She's diagnosed with schizophrenia, substance use disorder. She was adjudicated incompetent by a court 3 years ago, and the County Department of Social Services was appointed as her guardian of the person. She has no assets other than government benefits that she has in her which is managed by a representative payee. She's currently homeless, living on the street. She's been the subject of 2 involuntary commitments in the last 6 months. So that's sort of the history of Paula. But there has been a recent development, and the recent development is that Paula's grandmother, who is still involved in her life and cares very much for her, but was unable to take on guardianship herself because of her own challenges and ailments, is concerned about Paula. And so she has sought and filed a motion with the guardianship court expressing concerns about Paula's current condition. She puts in her motion with the court that Paula is living on the street, not receiving treatment, and engaging in sexual activity in exchange for drugs. So that's where we sort of find our scenario at the moment, and what we're going to each sort of approach some questions about and apply to this case scenario about those 3 areas of the law. So the first question that often comes up and that we were asked to sort of talk about today is about guardianship. And fundamentally, what does it mean that Paula was adjudicated incompetent and a court was appointed to a guardian was appointed to act on her behalf? In North Carolina, guardianship, we have what is called a substituted decision-making model. Effectively, what happens when that court adjudicated Paula incompetent is they took away her authority to make decisions for herself. That can be related to her property or her person, her health care, her finances. They removed her authority to make decisions from her, and they gave it to someone else. The court gave it to someone else, in this case, the County Department of Social Services. So we have that substituted decision-making model where we replace an individual's authority to make decisions when they lack capacity with the authority and give that authority to someone else. The model that we have in North Carolina related for guardianship, although we refer to it sort of as this monolith, as guardianship, it's really a 2-part legal process. The clerk of superior court is the presiding judicial official over both steps in this process. But before we get to the question of guardianship, the first question that the court is charged with answering is whether or not this person is an incompetent adult under North Carolina law. So they examine the incompetency. It's a high legal standard that's applied. It's the highest civil standard that we have. The court looks at whether or not there is sufficient evidence clear, cogent, and convincing evidence that the person is an incompetent adult. Only if the court answers that question in the affirmative do they move on to the second question, which is, what is the nature of the guardianship that is needed for this individual and who is going to serve in that role? The court's inquiry there is much more searching. It's a best interest standard, highly discretionary, and looking at what that person needs and who's going to best serve those needs. In that first stage, when the court is looking at the question of incompetency, so in Paula's case, what did the court look at likely when that case was brought before them? The legal standard for an incompetent adult in North Carolina is defined as an adult who lacks sufficient capacity, first to manage their own affairs. And that's really looking at the functional aspects of the individual's life. Are they taking their medication on time? Are they adhering to doctor's appointments? Are they able to prepare their own meals? Are they able to manage their finances? It's sort of looking at the external aspects of their life, the functional elements of managing their affairs. A person could also be deemed to lack capacity under North Carolina law if they, from sort of a cognitive analysis. So what they're looking at in the court system is, in the court proceeding, is sort of their ability, their reasoning, their insight to their diagnosis, their ability to make or communicate important decisions concerning their person, family, or property. So looking at sort of their insight, their reasoning, their appreciation of consequences of risk. But if an adult meets either of those, the functional managing their affairs or the cognitive piece of that definition, that insight, that reasoning, appreciation of risk and consequences, they would meet that first part of the definition of incompetent adult under North Carolina law. Oftentimes, there's a combination of evidence. There's evidence that supports that lack of functional capacity and evidence that supports the lack of cognitive capacity. Recently, you all changed and added a second part to the definition of incompetent adult. And effective January 1st, 2024, the second part of the definition requires the court to examine whether or not the adult's needs, their affairs, their ability to make or communicate decisions can be met through what is called a less restrictive alternative. So what am I talking about there? Think about powers of attorney, healthcare powers of attorney, supported decision-making, a representative payee to manage finances. So if you go in to do your estate planning, you sign a power of attorney, you sign a healthcare power of attorney, and you subsequently lose capacity, and your agent is making those decisions on your behalf, it is potential that even though you lack that functional capacity, you lack that cognitive capacity to exercise decision-making on your own behalf, you can do so effectively through your agents. And so you would not meet the standard of an incompetent adult under North Carolina law because you have those operating sufficient, less restrictive alternatives in place. So what does it mean in Paula's case that the court appointed specifically here a guardian of the person? So the court found her to lack that functional and cognitive capacity. They found the absence of less restrictive alternatives that were sufficiently enabling her to manage affairs or make decisions, and ultimately appointed a guardian of the person for her. So what are we talking about when we talk about the authority of a guardian of the person? They did not appoint a guardian of the estate. That's another type of guardian that can be appointed under North Carolina law to manage finances, property, assets of the individual. Because Paula only had government benefits that were being managed by a representative payee, the court did not appoint a guardian of the estate in this instance, but instead only appointed a guardian of the person. So what would guardian of the person have the authority to do on behalf of Paula? By law, the guardian of the person, unless limited, has the authority to provide for care, custody, and control of Paula. They have an affirmative obligation, not just to make sure that Paula is safe, but to essentially find and connect Paula with opportunities for training, education, employment, habilitation, and rehabilitation. So investing in the growth and development of Paula, not just responding to a crisis need. The guardian of the person also has the authority to establish her a place of abode, to seek out and determine where Paula resides. There must, by statute, the guardian must give preference to places that are not treatment facilities. If a treatment facility is required, then the guardian of the person has to give preference to community-based treatment facilities in making decisions around housing. So the other significant authority of a guardian of the person is that they have the authority to give consents and approvals. So that's legal, psychological, healthcare, mental health care consents, consent to treatment for that individual, for Paula in this case, which is a pretty significant authority and need that Paula may have given her lack of capacity and the facts of this case related to her mental health and substance use needs. Does the fact that Paula has a guardian of the person mean that she can be forced into treatment? This is often a common misunderstanding about guardianship. A guardian of the person, again, we're back to that idea, that concept of guardianship is about decision making, right? The guardian can give informed consent to medical and mental health care treatment. They have that power, they have that duty. They can be an effective advocate to help coordinate services, to arrange for housing, placement, or treatment. It was mentioned earlier, the transition from an involuntary commitment to an outpatient setting. If that had happened for Paula, the guardian could be an effective advocate for overseeing, for being aware of the appointments, for following up on the appointments, for following up on the medication needs, for arranging those medication needs, for assisting and supporting with that treatment and advocating for compliance with treatment recommendations and supporting Paula on that path. But guardianship in and of itself does not authorize confinement or forced treatment. Again, it's about decision making. It's about the authority to give that legal consent and help support the implementation of it. But guardianship law does not authorize, the guardian could not authorize confinement or forced treatment. So there are limits on what this guardian of the person could do for Paula. But there's a concern here, and there's a concern that's being raised in a motion before the guardianship court, before the clerk of superior court, who will have to rule on the motion. And one of the acute issues in Paula's case is that she is still living on the street, which is a concern. And I think here what we see is that ultimately one of the limitations of guardianship is that it doesn't necessarily guarantee compliance or resources. I think one of the main questions that the court is going to have for the guardian in particular is, what are you doing to carry out your role? Are you engaged with Paula? Are you engaged with Paula's treatment provider? What have you done to try to secure housing, to help support her in that transition to housing and to remaining in housing? A lot of times what we see is that guardians may be a family member or a close friend. That wasn't the case here in Paula's case, but somebody who's unfamiliar with the mental health system in North Carolina, with mental health care in general, and they don't know how to navigate the system and are not aware of what their authority is as a guardian. And so they may not be aware of their authority and they may not be carrying out their role. Another potential restraint that may be happening here is that Paula is refusing to remain in treatment, or there may not be available housing. There may be a lack of resources that support her. There may be a lack of beds for treatment for her. And so this combination of her potential refusal coupled with the potential for the lack of treatment, housing, or other resources that may be available to meet her needs may be issues at play in Paula's case. I think the sort of critical thing that I would want to sort of relay to you all about guardianship and thinking about guardianship is that guardianship is not, in fact, the service itself, right? Guardianship, in sort of thinking about what guardianship is, it is sort of the conduit for the service, right? The guardian can be an effective advocate, a support, a decision maker to give that informed consent to treatment, but the guardian is not the service, right? The guardian is not the medical provider or the substance use provider, treatment provider, but the guardian can be the conduit to connect that person to mental health treatment, to connect that person to housing assistance or medical care or substance use treatment. And so sort of thinking as the guardian as that conduit to whatever available resource might be there is a critical way to sort of apply the guardianship model. The last question sort of that often comes up is back to this motion. So Paula's grandmothers filed this motion with the court, raised these issues. What can the court do? The court retains jurisdiction after the appointment of a guardian and has oversight responsibility. There are some critical tools in the general statutes that empower the court to sort of require the guardian to file a guardianship plan and oversee the implementation of that guardianship plan or program. The court has the authority to order status reports, to hold status hearings. What are you doing, guardian, to carry out your role, to ensure that Paula is connected to housing, to ensure that Paula is getting appropriate medical care and mental health care. If the guardian fails to do that, the court can remove her guardian and appoint a new guardian. But I think two of those critical limitations still apply. The court in the guardianship proceeding can establish a guardianship plan or program, but ultimately that bed or that medical treatment has to be there for the guardian to be able to be that advocate and conduit to that particular resource or service. And also, the court is limited in what they can do in terms of ordering compliance. The court cannot enter an order in the guardianship proceeding that law enforcement pick up Paula and take her to treatment. That does not fall within the purview of a 35A guardianship proceeding. And that's where we sort of see the transition of Paula's case to my colleague and the world of involuntary commitment. And so I'm going to hand it off to him to talk a little bit about that process, given sort of the limitations that may exist in the guardianship arena.
Thank you, Meredith. Hello, I'm Mark Botts, one of the trio here from the School of Government. So Paula's guardian wants to admit Paula to a psychiatric inpatient facility, given her condition. Can she do this without using the involuntary commitment process? And the answer is yes. There's three ways an adult can be voluntarily admitted to an inpatient facility for psychiatric or substance use treatment. The column on the left here represents adults who, due to their mental status, have the capacity to give informed consent to treatment and who have not been adjudicated incompetent. So these people can admit themselves pursuant to their own consent to treatment, present themselves to the facility and consent to their own admission. There is a procedure in the State Mental Health Act governing the middle column, and that is people who have a psychiatric advance instruction or have executed a healthcare power of attorney and named a healthcare agent to make healthcare decisions for them, including mental health decisions. If Paula, for example, had done this before she was adjudicated incompetent, these are vehicles by which she could have admitted herself, either with a healthcare agent's consent to admission or her prior consent through a psychiatric advance instruction. A psychiatric advance instruction is for mental health treatment is for people who know they have a serious mental illness, and they know that sometimes they have decisional capacity and can give consent to treatment, but sometimes when they go through an acute phase of their illness, they lose that capacity. They don't have decisional capacity, but their advance instruction says, hey, when I get like this, I can be voluntarily admitted. You don't have to go through the IVC process. The other form of voluntary admission, the third column, is for adults adjudicated incompetent, which in this case would be Paula, and the admission is with the consent of the guardian, not Paula's consent, because having been adjudicated incompetent, she lacks the legal capacity to give her own consent to treatment. Unlike the first two columns, the third column, where we're dealing with Paula and the guardian admitting her, this requires an additional judicial proceeding that's separate from the guardianship proceeding. So if Paula does not want to be voluntarily admitted, but the guardian seeks voluntary admission, is it still voluntary? Paula doesn't want to go. The guardian says, no, I want you to go. You know, if we can get Paula there, is it voluntary? And the answer is it still is voluntary because the guardian acts on behalf of the person adjudicated incompetent, and applying for the admission to the facility, they have to actually submit a written signed statement at the facility, and Paula has to be there. And that written application becomes the initiating document that starts a legal case, just like an affidavit and petition in an IVC case starts a legal case. And then the guardian also acts on behalf of Paula when it comes to consenting to specific treatments or medications once she's in the facility. And the standard is mental illness or substance abuser and in need of treatment. The facility must evaluate Paula to see if she meets that standard. And then, because we're talking about inpatient treatment, a district court judge must review and concur that that standard has been met. If we were talking about outpatient services for Paula, outpatient mental health and SUD services, there's no judicial procedure. But for a locked inpatient facility, there's a judicial procedure. Now, the differences between involuntary commitment and voluntary admission, because in both cases, Paula might not really want to do it. But in the voluntary admission, she has a court-appointed guardian to can act on her behalf. The difference between involuntary and voluntary really comes primarily to, it comes down to two things. One, getting Paula to the facility. There is no law enforcement transportation to help the guardian get Paula, if she doesn't want to go, to the facility. And the guardian has no authority to use force and restraint. I don't know, like if I was wanting to get Representative Pirtle to the facility, you're bigger than me. I don't think I would want to try to wrestle you and exercise force and restraint if I'm your guardian, right? So that may seem like a silly example, but that shows that if you don't have the cooperation of the ward, even though the guardian has the legal authority to act on behalf of the ward, that doesn't mean as a practical matter they can make things happen. So the difference is IVC, you have law enforcement transport. Voluntary admission, you don't. And then the other difference is is a lesser standard for voluntary admission. There's no need to find dangerousness. It's just mental illness, substance use disorder, and in need of treatment at that facility. Does Paula's incompetency finding affect involuntary commitment or voluntary admission? And the answer is no. The statutory law currently says that a finding of incompetency does not answer the question before the court of whether someone meets the involuntary commitment standard or the voluntary admission standard. Conversely, if someone's been involuntarily committed or voluntarily admitted, each one requiring its own separate judicial proceeding, each one having their own separate standard, that does not affect an incompetency proceeding. And the reason it doesn't is that, as Meredith started out in the beginning, each one of these proceedings, an adjudication of incompetency, an involuntary commitment case, a voluntary admission of Paula, they all present different questions to the court and involve different legal standards. That's why you cannot substitute one for the other. However, someone involved in these three proceedings could be involved in one or more of them because of the same mental disability or disorder. The same underlying mental condition could lead to any of these three. And the facts might be the same in any one of or all three of these cases. I was asked to say something about the voluntary, what we just talked about was the voluntary admission of someone to a psychiatric or substance use disorder treatment facility. I was asked to say something about the voluntary admission of someone to a facility for intellectual and developmental disability services. Someone with an IDD who has not been adjudicated incompetent may be admitted pursuant to their own consent. So you can have an intellectual or developmental disability. If you've not been adjudicated incompetent, you still have the authority to admit yourself pursuant to your own consent to a facility for IDD services. On the other hand, if you've been adjudicated incompetent, like with mental health and SUD facilities, the guardian is going to act on your behalf. And I believe we're next. Shay Denning, my colleague, is next up.
Hello. Good morning. I think it is still morning. So we are now at the stage of our problem where Paula's problems have gotten worse. Paula has now been arrested for drug possession. And the question is, what's the impact of the fact that she's been adjudicated incompetent and appointed a guardian on those criminal proceedings? And the way I would describe that is that this adjudication of incompetency is relevant, but not dispositive. First, a person who has been adjudicated incompetent may still be held responsible, found guilty of, convicted of criminal conduct, criminal activity. An adjudication of incompetency does not excuse criminal behavior. So if you have assaults, thefts, or in Paula's case, a drug offense, that a person adjudicated incompetent may be appropriately convicted of those offenses. There are some exceptions for some crimes that require an affirmative act by a defendant. So, for example, the failure to file a tax return. There may be some question about whether Paula could be adjudicated as criminally responsible for that kind of behavior given her incompetency and guardianship. But in general, this is not, incompetency is not a legal excuse for criminal activity. The next question is whether this adjudication for incompetency means that Paula is not capable to be tried for the drug possession charges. And the answer to that is not necessarily. Mark just mentioned to you that while incompetency and incapacity and involuntary commitment may all relate to some cognitive deficiencies and mental illness, they do not all use the same standard. So Meredith talked to you about the standard for incompetency. I'm going to talk to you really briefly about the standard for incapacity. The words sound really similar. People in the vernacular mix them all up, but they mean different things. So what is the standard for capacity to proceed in a criminal proceeding, and why are we looking at that? We're looking at that because both the federal and state constitutions and our state statutes prohibit the trial and punishment of a person who is incapable of proceeding. So what does that mean? What does it mean to lack the capacity to proceed? It means that by reason of a mental illness or a mental defect, so this is not all about mental illness, it could be traumatic brain injury or some other sort of mental defect, the person can't understand the nature of the proceedings, they can't understand what they have to do with the proceedings, or number three, and this is by far the most commonly relied upon standard, the person's mental illness or mental defect prevents them from assisting in their defense in a rational or reasonable manner. Now, obviously, the very condition that led to the adjudication of incompetency may be the same condition that is preventing the person from assisting in their defense. But a finding that adjudication of incompetency is not determinative as to whether those criminal charges can proceed. It is a different legal standard. The court's going to have to undertake its own inquiry. Most of the time, that involves an examination by a mental health professional, followed by a hearing, and then a determination by the court as to whether this standard is met. So what happens? What happens if a court does, in fact, determine that this person that Paula is incapable of proceeding? There are two main effects. First, the criminal prosecution has to stop. It has to halt. It may be a pause that is later resumed, but for right now, it cannot go ahead. So there can't be a guilty plea, there can't be a trial, there can't be a sentence. The case will remain pending unless it's dismissed, and there's some statutory timelines about when that has to occur. Second, if a trial court determines that a criminal defendant lacks capacity to proceed, the trial court must then consider whether the defendant meets the standard for involuntary commitment, so mentally ill and dangerous to self or others. Those proceedings generally are just like any other involuntary commitment proceeding from there. What is different, though, is that when a person is involuntarily committed following a determination that they are incapable to proceed, those folks, if they are treated in the state hospital, will receive some capacity restoration treatment. That will be part of what happens. Capacity restoration also is part of a pilot project in some county jails now. So some of the folks who are incapable to proceed may participate in programs. One of the programs is called NC Rise, and folks may receive jail-based capacity restoration services. This intersection between involuntary commitment and capacity restoration is where you all may be hearing some frustration. And that frustration has been articulated by court personnel, by law enforcement, and by treatment providers. The system can't keep up with the number of incapable defendants. So what happens is that defendants may be found incapable to proceed, and they can't go right away to a state hospital for those capacity restoration services. Instead, they sit in jail. If the jail has capacity restoration services, that may be a bridge, but some of them may sit in jail 4, 5, 6 months awaiting placement in a state hospital. In misdemeanor cases, they may never get there at all. many of those non-violent misdemeanor offenses are never going to, those people are not going to make their way to the state hospital. So, what's the guardian's role here if Paula is incapable of proceeding? Legally here, Paula decides her own fate, and the criminal proceedings can go ahead only if she gains capacity. So Meredith and Mark talked about places where a guardian can be a substitute decision maker. That's really limited or non-existent in the criminal context. So a guardian cannot enter a guilty plea in a criminal case on behalf of a defendant, regardless of whether a defendant is capable or incapable of proceeding. If Paula is deemed capable, the guardian can't prevent the entry of a guilty plea. That said, a guardian can still be helpful. If the guardian is someone with whom Paula has an existing relationship, that might be somebody Paula trusts who can help kind of navigate Paula through this system. They can also arrange for services if Paula is perhaps out on pretrial release. So the guardian can have an important role as a practical matter, but their legal significance is pretty limited in the criminal context. And there are a couple of cases here acknowledging that principle. So my colleagues covered most of this, but I'll go ahead since I'm standing here and kind of go through the key takeaways. And the first is that guardianship is really about removing decision-making authority from one person and giving it to somebody else. The guardian is a conduit. They are connecting the person with available services. They are not the provider of those services. Guardianship doesn't replace involuntary commitment procedures, and there is the relationship that Mark has described between voluntary admission and the provisions in 122C for involuntary commitment. And a civil determination of incompetency is related to, but doesn't determine whether a person is capable to proceed in a criminal matter. So with that, I'll step back and maybe make room for my colleagues so that you all can field questions and I can ask them to answer.
Questions from members of the committee before me? Representative White.
So basically, it sounds like that. Is Paula still on the street?
You know, when we were talking...
I know this is hypothetical, but I'm asking a question about someone that would...
When we were talking about this scenario, Meredith and I were sitting in her office yesterday saying, there are not good answers for Paula. And we wanted to come with with some sort of scenario that has this perfect answer, and there aren't good answers. So I'm going to let Meredith come up.
I mean, I think one of the critical questions for the court, particularly in the guardianship, is the guardian doing what they need to do to ensure, you know, in this case, has Paula been connected to a mental health provider? Who is that mental health provider? She's been IVC'd twice in the last couple of months, in the last 6 months. What was the plan, the recommendation for ongoing treatment after those IVCs? Has that been adhered to? I think there can be a significant role for the court in overseeing the guardian and for the guardian in being an adequate and effective support for Paula in implementing whatever treatment plans have been proposed. But there is a sort of significant swirl that we get caught in terms of if Paula is non-compliant with those plans and ultimately she's not willing to remain in the housing that has been found for her and secured, and she leaves and returns and is living on the street. I'll let you kind of fill in the IVC piece.
I just wanted to say that by virtue of being the guardian has access to all of Paula's confidential treatment information. So in the guardian carrying out their duty to try to arrange and provide for services, they can call the LME-MCO or the LME-MCO provider. They can talk and find out, does she have a provider? If she does, has she been coming and getting treatment? If not, why has she not been engaged? So there is the ability of the guardian to access information and try to navigate the system and figure out what Paula's getting. If she's not getting what she needs, why? So there's that. But in terms of, so the guardian, though, is a facilitator, very important role, like sometimes a parent for a child, right, who has decision-making authority and has to arrange things for their minor child. But in the case of an adult versus a minor, it's hard to just pick that person up, put them in the car, and take them somewhere they don't want to go. So that's why sometimes Paula can be on the street. Maybe the guardian's doing all they can do, maybe they're not. But even when they're doing all they can do, there's limits because you need Paula's cooperation. Also, it may be that it's difficult to access services because to arrange services, the services have to be out there and you have to have a way to pay for the service.
Paula, I think it's real interesting that you all have presented this at this moment because, you know, I guess this is why we have Irina's Law. Would that be a fair statement to make? And you don't have to answer that, it's rhetorical. But obviously the system is very broke. And having been a public health nurse and having dealt with a lot of folks that were not doing their job in the different departments where the, the guardians are usually appointed from, I think this is, what you've said to me, what you shared with us today, sounds like the problem still exists, and that's why we're here today. Thank you so much for your report.
Other questions from members? Representative Morey.
Thank you, and thanks for a great example discussion about it, and trying to take it back to Irina's Law and why we passed it. We had the defendant, who is the subject of this and other cases, in January, arrested for misuse of a 911 call. And correct me if I'm wrong, but oftentimes we determine the future if it is a violent crime or a nonviolent crime, especially misdemeanors. And I think, Professor Denning, you said the system can't keep up with the incapacity to proceed. They can wait in jail for months. Misdemeanor cases never get there. They do not make it to state hospitals. And is it right that, up until we passed this law, so much of the way the case went was determined by the classification felony, misdemeanor, violent, nonviolent? Would that be fair?
Yes, the felony cases are proceeding through a track where if the person is committed, they will go to the state hospital. If there is a designation that the offense is violent, they also wind up in the queue for the state hospital. But if you're talking about a nonviolent offense, even a nonviolent felony offense like felony stalking, those folks are unlikely to ever make it to the state hospital for that kind of treatment. And so what can happen is they can be involuntarily committed. That has a whole host of other complications related to hospitals and their willingness to, other 24-hour facilities, their willingness to take on people with pending criminal charges or lack of willingness to do that. And Mark, you may have thoughts about that.
Yeah, I just want to say, so one thing similar about the incapacity to proceed finding and Irina's Law is incapacity to proceed uses the criminal process to identify someone who might meet the involuntary commitment criteria. And if so, the judge issues the order for the person to be taken to a state hospital if it's a violent offense. Like Shay says, that person may never get there, not because of lack of beds, but because of lack of staffing, okay? Irina's Law does a similar thing. It uses criminal process, a certain stage, to identify, the magistrate, when they're considering conditions of pretrial release, are there reasonable grounds to believe this person might be dangerous, mentally ill and dangerous self for others? If so, they issue an order that starts the involuntary commitment process, sends someone into the IBC process, just like an incapacity to proceed defendant might be sent into the IBC process from the criminal court judge. They go into the process, but that doesn't mean they get to the end of the process, okay? That doesn't mean that they necessarily get to an inpatient facility. That doesn't mean they will necessarily get treatment. And even if they do get to the facility and get inpatient treatment, at some point they're going to be discharged. What are they going to be discharged to, okay? And when you enacted Arena's law, there are a couple of provisions you put in there about discharge relating to someone who has a violent offense and a prior commitment order, saying, well, there has to be discharge planning. You know, is there a safe place for them to discharge to? Will they go back and have someone monitoring their medication? Will they have housing? You did that for a segment of people, but the way you wrote it, it would not cover even all the cases we're talking about. So I guess that's to say there's limitations, which is the big word we've been using.
Thank you. And I think to clarify, just to follow up, I believe the committee had scheduled a district court judge from Orange County who wrote me an email who I think said her frustrations, and if I can just for a second say what Judge Samantha Cabe said, one of the most important things for a committee to know is when the charge is, quote, a nonviolent misdemeanor, which most misdemeanors are, including the misuse of a 911, the law only allows us to order a local evaluation. However, local hospitals can and do refuse to hold them for the evaluation. They cannot hold them without an allegation of danger to self or others, i.e. in a 911 call. So these folks have to either be released with a date and time to appear for their evaluation or held in the jail. And I think that is one of the frustrations, that they know this person needs help. This person may not be immediate danger to the self or other, but there's an accentuated, increasing mental health issue. But I think this is one of the gaps that we may need to address that we have not done with Irena's law. Thank you.
Other questions from members of the committee? I have a few. Referring, I guess, to Paula's case, and we're dealing with an involuntary, a voluntary commitment potential that the guardian can say, I want to put you in a mental health facility, and she has to go to the court, and the court can listen to it, and he say, yeah, you're entirely right, guardian. Good luck getting Paula to go. Is that roughly where we are with that proceeding?
It's slightly different than that. The guardian has to show up at a given facility with Paula. So the part that's hard and the stage at which Paula needs to get to the facility is at the very beginning when the guardian wants to complete a written application to admit Paula. So if Paula's with the guardian signs the application, the facility takes Paula in, they do an evaluation. The evaluation and the written application of the guardian gets sent to the clerk of court, which triggers the clerk of court's duty to calendar a hearing. So the judge does not even get the case until and unless Paula has gone into the facility.
Okay. Variation. Let's say Paula goes with the guardian. Judge agrees. She is admitted. Can Paula decide she wants to leave?
No.
How does she get out?
She gets out if the court, there's three ways. The legally responsible person, the guardian, can apply to the court to have her discharged.
On what grounds?
On the grounds that she's no longer either mentally ill. She's either no longer mentally ill or she is mentally ill and no longer in need of treatment at this facility. Okay, so the guardian can apply to the court to have Paula released, discharged. Otherwise, it's only upon the discretion of the court or the facility to discharge Paula.
So from Paula's perspective, if she makes the mistake of showing up the first time, she may be stuck.
Correct.
Unless the court or her guardian
Correct.
changes their view
Correct.
of her mental illness or need for treatment.
Yes.
Dangerousness doesn't enter into it.
That's right.
Okay, so the standard is lower from keeping you if you went there theoretically voluntarily.
That's right. That's right.
With reference to involuntary commitment and the dangerousness standard, is that standard required by federal courts or some sort of constitutional law? Could that standard be changed? Could we say, for example, you can be involuntarily committed if you have some level of mental illness and are in need of treatment?
That's a great question.
Good.
I've been listening, and you've been asking great questions. You just asked me a really hard one. Okay. The answer is that federal law, Supreme Court precedent, says that you cannot confine someone in this way unless they're dangerous to themselves or others. Okay.
That's the specific standard, because that's not my understanding, that it said that specific standard.
Well, the caveat to that, the way I would qualify it is states, under state law, define what dangerousness is. So if a state wanted to, say, have the definition of dangerousness be more expansive and capture more people, it could define dangerousness that way, whereas another state could define it very narrowly. And then I would go on to say that, a lot of people say mistakenly, even in North Carolina, you have to be imminently dangerous to be involuntarily committed. Imminence is not a part of our definition. And our definitions are actually fairly broad, but are not always applied that way. But there is a certain level under constitutional law to deprive someone of their liberty for non-criminal purposes. The person has to be considered dangerous.
So theoretically, we might say you are dangerous to yourself or others, or if you are mentally ill in some degree and in need of treatment.
Well, if you were just wanted to say mentally ill and in need of treatment, then I don't think you could confine someone to a locked facility under federal law, federal constitutional law. But if you want, I can look at that. And I think right now we have there are actually 6 ways to be dangerous, 6 definitions in North Carolina for commitment purposes. One is lack of self-care ability. If you are unable to exercise self-control, judgment in the conduct of your daily affairs, eating, nutrition, housing, and because of that, there's a reasonable probability you might suffer serious physical debilitation in the near future, then you're considered dangerous. So if you were like people are looking at veterans who lack housing and those kinds of things, we already have a fairly expansive definition. I guess if I was your lawyer, and instead of saying change the standard to you are mentally ill and in need of treatment, I would say work with the definitions of dangerousness and see if they are already sufficiently or could be more expansive to try to capture the folks you want to capture, if that's your goal.
One more question, fairly esoteric, I guess. A guardian may not enter a guilty plea in a criminal case on behalf of a defendant, whether the defendant is capable or incapable to proceed or incompetent, I would say. And you're citing cases from the Court of Appeals in Oregon and from I guess it's the Superior Court in Massachusetts. Are those cases aren't binding on us, are they?
Absolutely not. Those are just cases. It's an unusual circumstance in which this arises. So those just happen to be two reported cases addressing this issue. We don't have any North Carolina cases on point, but I think that the principles there would be likely to be applied by our North Carolina courts.
Is it conceivable that we could change the law in North Carolina to allow a guardian in case of incompetence to enter some type of plea on behalf of their ward that might be designed to at least get them treatment or get them to a stage that doesn't just means, well, you know, it's a misdemeanor nonviolent, so you're back out on the street and we hope nothing bad will happen?
I think there would be a constitutional bar to that. The second case cited there, the case out of Oregon, involved a situation where arguably it would have, and this was a lawyer who was, it's analyzed under the same guardianship framework because the lawyer was essentially trying to serve as a substitute decision maker, and it would have arguably been in the client's interest for him to do that and resolve the case, and the court said that that was not permissible under the Constitution because of the requirements that a defendant personally, knowingly, voluntarily, and intelligently waive certain rights to plead guilty. So I think there would be some barriers to that.
Okay.
I just wanted to add to clarify something in our last question. You can be committed in North Carolina without being dangerous, but that would be to outpatient commitment. So that doesn't require a finding of dangerousness.
Representative Green.
Yes, thank you, Mr. Chairman, and thank you all for being here in your presentation. We've talked a lot about what can happen if someone has a guardian. My question kind of relates to getting somebody a guardian in the first place. Who has the right or the standing to make a motion for guardianship? Could, let's say, for example, with Paula's case, let's say she had been involuntarily committed and the treatment provider felt like upon discharge she could benefit from having the conduit to these services and navigating that whole thing. Can that treatment provider make that motion for capacity, guardianship capacity, so forth, to be evaluated, and the possible appointment of a guardian?
Yeah, that's a great question. And we actually have a very expansive authority under North Carolina law. The statute says any person may file for guardianship. It doesn't say any interested person or any family member or any friend. It's a very broad standard of who can file that petition for incompetency in North Carolina. It could include a county department of social services, a healthcare provider, a hospital, a nursing facility, a family member, a friend. And there's actually a specific provision in the statute that allows for healthcare providers to file without the need for legal counsel. So they can file, as unrepresented through like a social worker at the hospital, and sometimes do. So, and that sort of goes to the protective nature of the proceedings. I think from a policy standpoint, we want them to be accessible for people who need that protective service of a guardian, for the courthouse doors to be open to them. So the statute is any person may file. It's very broad.
Thank you.
Yes, sir.
Thank you, folks. We're fortunate to have School of Government and you folks to come over, and we'll see if the education sticks.
We're always welcome to come back. Thank you for having us.
Thank you.
Our final presentation this morning is on involuntary commitment in North Carolina. That overlaps a little bit with the last. In this instance, Dr. Christopher Sharp, who is Senior Fellow with the Cicero Institute, is here. Welcome, Dr. Sharp.
As background, many years ago, as a probation officer in Central Florida, worked heavily with mentally ill offenders, wrote a post-booking diversion program for Seminole County, Florida, that was in place for about 15 years, specifically because we had problems with involuntary commitment and mentally ill offenders in the community. I'm also a retired Army officer, worked heavily with human terrain teams, and more of a problem-solving model, which will become part of this conversation. And I've been an academic working on mentally ill offenders specifically for about 30 years now. So what I'd like to do is start off with the federal positions, because that kind of lays the landscape for where we are and how states can react. So prior to the current administration, there were several consent decrees from the Department of Justice that were based off of a definition of integrated setting and the right to refuse treatment. Those consent decrees are being reversed en masse across the United States. So lawsuits are being dropped against states based off that integrated setting model. The reason why, when we looked at the Department of Justice, they were basing their decisions off of an incorrect interpretation of the Olmstead decision. They were looking specifically at Title III of the American with Disabilities Act, which had a very vague definition of integrated setting. The Olmstead decision was based off of Title II, which looked at integrated setting based off of the treatment provider's recommendation, as well as the ability of the state to meet those needs. I'll get to that in a second. That then led to the Health and Human Services and SAMHSA to then create policies and regulations that even further narrowed that definition into imminent danger, which was just discussed. That focused on really the danger to self or others, and unfortunately, that narrow definition has caused deinstitutionalization or reinstitutionalization of a lot of severely mentally ill in jails, prisons, the homeless community, and especially in our emergency rooms. Now, that imminent health or that imminent threat that is currently being used by most states, strangely, the National Institute of Health, when they looked at involuntary civil commitment, they focused on both the short-term harms of civil commitment, meaning that there was just trauma from being taken into custody and put into commitment, but they admitted that the long-term benefits of civil commitment and the quality of life were incredibly important, and there was a great deal of significance in those long-term quality of life benefits. My own personal experience, my wife's aunt was a profound schizophrenic in the state of Iowa. She was involuntarily committed and forced to take, they were long-term injectables. As a result of that, initially, there was some pain and there was trauma. However, she underwent those long-term injectables for 40 years. In that time, she was able to live in the community, get a job, get remarried, have a good life, and live well into her late 60s. This is ultimately what we're trying to get to. Now, what I do want to talk about in North Carolina, you have all of the elements for a very robust civil commitment program. It's all in statute. But as has been noted by several of the presenters, it's getting that information, these different systems to talk to each other. So what I want to focus on now are some of the numbers on where these individuals are going. So 2013 is being used as a baseline for deinstitutionalization, largely because of the HEART Act. 2009, under the Obama administration, the HEART Act created what we knew as housing first. The focus was no longer on treatment. It was just get them a house, regardless of treatment. We'll have them have access to treatment, but that was a direct response to what was before that in the treatment first model, meaning that someone had to go and complete treatment in order to get housing. If you've ever dealt with someone with severe mental illness, that doesn't go away. Addiction can be overcome. The severe mental illness is lifelong. That is important because those individuals would never be housed. So that's why we focus on 2013 as kind of our baseline, because that's where the money followed the HEART Act. Now, in North Carolina, overall homeless numbers in 2013 were 12,168. You had 43% of them in emergency shelters, 31% in transitional housing, and 26% unsheltered. The total beds at that time for homelessness were 16,202. There were more beds than there were homeless in North Carolina. In 2024, overall homeless numbers dropped. This is important. 11,626. 49% of them were in emergency shelters, 12% in transitional housing, and 40% were unsheltered. Again, the total homeless beds in North Carolina were 22,039. Again, almost twice as many beds as there were homeless people. However, what we saw was a concentration of the severely mentally ill in the homeless population. So while in 2013, there were 264 severely mentally ill homeless people on the streets, by 2024, that number had increased to 746. Alternatively, the severely addicted dropped from 759 in 2013 to 455. That is a testament to North Carolina's focus on addiction and telehealth and all the programs that North Carolina has to address chronic addiction. Those are important things, but the population that's still being left out in the cold, literally, are the severely mentally ill. So, while the overall percentages went down, again, what we're seeing is that concentration of the severely mentally ill out on the streets. In 2013, over 4,000, going to the prisons now, in 2013, over 4,000 of the state prison population were identified as severely mentally ill. By 2024, this had doubled to 8,000. So they're being reinstitutionalized into a facility that is incapable of providing the necessary treatment that they have. Yes, they do provide mental health treatment, but that's to basically create a compliant inmate as opposed to really addressing the severe mental illness. Now, when we go to the jails, the North Carolina specific information for mentally ill inmates in jails is relatively unknown, but the assumption is that about 44% of the population in the county jails were severely mentally ill. By 2024, that number had increased to 50%. So again, a highly transient population ending up in the jails that the county sheriffs have to deal with. I will address later on in the presentation how we can start to focus on that group. In 2013, moving to the emergency rooms, in 2013, there were 162,000 behavioral health intakes in North Carolina in the general hospitals. This increased by 65%. The latest numbers were in 2022. Later data is not currently available, but the state psychiatric beds during that same time dropped from 3,210 to 857 between 2013 and 2025. It's a 73% decrease. And additionally, in 2025, there were 300 psychiatric beds that sat unused by the very people that needed them. For context, this would address the treatment needs of approximately 40% of your unsheltered, severely mentally ill. Now, the question has come up before, why do we have these empty beds and not put people in them? A lot of that comes down to the way that these beds are accredited. Currently, the Joint Commission accredits approximately 88% of the hospitals across the country. They set up very specific standards in order to receive deemed status, which then opens up the gates for federal funding. What we have found is that state licensure requirements are actually much more stringent in terms of CMS requirements for psychiatric hospitals. North Carolina's standards for psychiatric hospitals are more stringent than what CMS requires and what the Joint Commission accredits on. So what we're doing is we're trying to work with the federal government to say that these standards need to be based off of state licensing requirements. You go out, you actually investigate, you audit these state hospitals much more often than the Joint Commission requires. You do this annually. And in the case of Washington State, for example, the Joint Commission came in, they did their 3-year inspection, and they said, the entire system is good to go. We like the way it is. Washington State said, we are not happy with this. They were getting ready to shut down 6 of their facilities because they didn't meet the state licensing requirements. Now, I could not find if North Carolina fell into the same position with their hospitals, but what we're seeing is that the state licensing requirements are often much better. And again, North Carolina is no different in those requirements. So the current state of involuntary commitments in North Carolina, again, as I said, North Carolina already has the elements for a very robust system. If you receive my slides, there are notes, there are several statutes. The prior presenters talked about the dangerousness standard in North Carolina. I personally love North Carolina's standard of dangerousness. I think it is very comprehensive. It does exactly what it needs to be and what it needs to do because it looks at deteriorating condition. Not just imminent harm to self or others, because at that point in time, we have failed that individual. If that person has gotten to the point where they're suicidal or homicidal, there are definite markers up to that point where we could have intervened in a more meaningful way. And North Carolina statutes allow for that. Now, under Section 122C-3, the individual has acted in such a way as to show all of the following. First off, suffering serious physical debilitation, showing a behavior that is grossly irrational or actions that the individual is unable to control. This is a deteriorating condition standard, which is incredibly important. Your first responders, law enforcement, EMS, they see this on a daily basis. And so that standard needs to stay in there. What I would add, though, is a standard of property damage, because there are precursors in dangerousness when we talk about misdemeanors of, for instance, arson. I was out testifying in Nebraska, and we were talking about specifically property damage, and the case of arson came up. They had entire homeless encampments that were burned to the ground by individuals who were mentally ill and frankly trying to stay warm. These were unintentional arsons, but this property damage, and when they found the person that did that, they saw several prior arrests for property-related crimes. Adding property damage to a standard of dangerousness to show the continuum of a person's behavior is an important aspect of that dangerousness to self. I also, in my notes, talked about domestic violence. That was something that was near and dear to my heart. I work domestic violence cases regularly. And if you know anything about the cycle of domestic violence and how that perpetuates, there is damage to property long before there is damage to that other person. And so, again, looking at those precursors, this is where property damage becomes an important aspect of that definition of dangerousness. Couple statistics based off of that: mental illness is present in roughly 15% of domestic violence perpetrators. Chronic addiction and substance abuse is present in 61% of domestic violence perpetrators. Again, this is showing those connections. Unfortunately, we look at property damage as completely separate. And one of the things that I hope to do in this presentation is look at, even when we're looking beyond involuntary commitment, there are several things that feed into involuntary commitment and can actually help with North Carolina's system. Let's see. Chronic addiction. Currently, there is a carve-out in statute for opioids, but alcohol and or just general chemical dependency that leads to that deteriorating condition should be included. Currently, it's not. I understand that opioids are the flavor of the day. That is what we're most focused on, but there are several other substances out there that cause the same behavior. Alcohol, frankly, being one of the most common. When you look at the impact of alcohol on someone's behavior and the inhibitions, that becomes a huge concern. Moving on to how we build access. The PAMIs, Disability Rights North Carolina, their purpose is to ensure that the civil rights of individuals going through the system are protected. That is their federal mandate. The PAMI Act authorizes Disability Rights North Carolina to investigate abuse and neglect against people with mental health disabilities and to advocate for their legal rights. Again, no issue with that. However, that scope is expanded to move people from institutions to the community. This has been shown by the reduction in psychiatric beds, by the number of beds that are unused, by the adherence to Joint Commission standards for psychiatric hospitals. And again, those standards, a psychiatric hospital would have to have the same medical apparatus as a cardiac unit or an orthopedic unit. That is not necessary for a psychiatric hospital. So they're maintaining different standards for institutions that frankly have a very different focus. Okay, so, and that, when we talk about how do we combat that, this is where the attorneys general come into play. And they can actually petition the federal government to change that or to refocus disability rights in the PAMIs on exactly what they're supposed to be doing in the protection of civil rights. Again, that focus on moving people from institutions was based off of this idea of a right to refuse treatment. Not a right to treatment, but a right to refuse treatment. Arguably, someone who is chronically addicted or severely mentally ill cannot make that decision on whether or not they should or should not partake in treatment. Again, my wife's aunt, my stepfather, he is also bipolar, and up until the point that he was medicated, he could not arguably make that decision in a coherent manner. So that right to treatment is very important. This is included actions. So because of Disability Rights North Carolina and their focus on moving people from institutions to the community, they've used multiple lawsuits to do so. And this is included actions against your residential facilities here in North Carolina. Now, there is a concern that involuntary commitment will include people with developmental disabilities. That is a fair concern. There is a lot of comorbidity. Very rarely do people have just schizophrenia or just addiction. Usually they have several conditions that come together to include developmental disabilities. However, you can carve those out to focus on specific severe mental illness and addiction and or developmental disabilities. For example, long-term injectables. My wife's aunt, when she got the long-term injectables, she would get them once a year. And every year that she got those, she had to be constrained to get the injectable. And then after that, she hit equilibrium and she was fine. After the first 3 years, though, she didn't fight anymore because she saw the benefits of these long-term injectables. And again, as I mentioned, she lived a very long and happy life. Now, when we look at the policies regarding serious mental illness, there are a lot of assumptions that are made about the mentally ill across the board, across the country. First off, that they're nonviolent. What I want to do, though, is focus on specifically the big three that you see up there: schizophrenia, bipolar disorder, and major depression. When you carve out those specific psychiatric disorders, you see the violence rates go up significantly. And that, when we talk about involuntary civil commitment, that is what we need to focus on. Unfortunately, and I'll get into a little bit later, we have the certified community behavioral health centers that do focus on these, but the federally qualified health centers, which also provide behavioral health, focus on what we call the worried well. Those with anxiety, minor depression, maybe they don't get along with partners, they have problems socially adapting, whatever the case may be. Those are conditions that are treatable. They can get whatever help they need and move on. Severe mental illness, as I said, doesn't go away and it does degrade. It ultimately will end up in violence and that degradation of either physical or mental capacity. And this is especially true with manic episodes and bipolar disorder. And again, using my stepfather as an example of that, he is very bipolar. And when he hits his manic episodes, he lashes out as part of that manic episode. So in an institution, 65, and again, these are North Carolina numbers, 65% of individuals in a comprehensive developmental disability and mental illness program fit into one of these three disorders: schizophrenia, bipolar, or major depression. 18% of those in supportive programs, meaning they're out in the community, they have supportive housing, they have access to treatment, they have one of these three conditions. Now, again, that underlying mental illness can be controlled through the long-term medication, and then that allows the treatment providers to focus on the developmental disabilities, the addiction, whatever the case may be. This isn't a one-size-fits-all or a magic bullet. It is a system of systems that allows us to address the overall problem. So in building capacity, moving to prisons and the prison population, United States Attorney General currently has the ability to involuntarily civilly commit sexual predators. Carte blanche. Someone being released from prison who is a known sexual predator, they can move straight from the prison into a residential facility, no questions asked. They can do the same thing with someone who is severely mentally ill and has received treatment for that severe mental illness while in prison, they can be moved from the prison into a residential facility, no questions asked. The same power has been given to every single one of the states through the Attorney General. That is a fairly significant portion of the population. When you look at, in the homeless population, I believe North Carolina's sex offender, sexual predator population in the homeless population is 16%. Looking at those individuals to see who meets that federal standard of sexual predator has the potential to take a lot of players and put them into residential treatment facilities. And I actually have some research specific to North Carolina on where those facilities can be and how to pay for them. What we want to do, though, is we want to look at a continuum, because right now we have an either-or situation. It's either fully residential or fully community-based. The reality is not everybody needs either fully residential or fully community-based. There has got to be a continuum. There's got to be a continuum of supported housing where assisted outpatient treatment, assertive community treatment, and forensic assertive community treatment comes into play. AOT, ACT are both civilly based. They've been discussed before. I'm a huge fan of those. I personally worked in forensic assertive community treatment that was criminally based. These were people that were involved with the criminal justice system. We realized that they had a severe mental illness, and we diverted them into this program to get them into the community, get them the intensive supervision that they needed. But to do that, I actually had to ride around in a car with a mental health provider and get certified to do intakes myself for the county. That was actually very beneficial, and this was long before we ever adopted a CIT or mobile crisis unit or even LEAD. And I'll talk about that in a little bit as well. The psychiatric hospitals, halfway houses, and the therapeutic communities do not need to maintain the same standards as just general hospitals and in those CMS accreditation standards, as I've noted. To reduce the overall prison population, one of the methods not related to involuntary civil commitment would be work for time credits. Looking at the indeterminate portion of a prisoner's sentence and allowing them to work time off of their sentence, meaning that they go out, they either apprentice or they're working in the community, they now earn time off of their sentence. That reduces the population in the prison. Again, reduces the burden to North Carolina's Department of Corrections. There are also public-private partnerships. Now, I know North Carolina had a private prison that closed in 2021. I am not advocating for a private prison. I am not advocating for a private facility, private incarceration in any way, shape, or form. What I do advocate for is looking at the potential for partnerships between private providers and public institutions. If the public institutions do the incarceration well, the sheltering, the feeding, and all of that, but maybe not so much on the treatment. As I mentioned, there are some barriers to effective mental health treatment in our prisons and jails. Maybe partnering with private providers or community-based providers not only helps reduce some of that burden, but provides that continuity of care post-release. The question then becomes, how do we get to that point? So in jails, there's an even easier method. Failure to appear warrants currently account for, on average, 15% of daily jail intakes in North Carolina. That is, and 82% of those are traffic misdemeanors. Total jail intakes in North Carolina are 128,000 annually, meaning that 19,200 are for failure to appear warrants. Largely for cases that would not require jail, that would not impose any kind of incarceration at all. Those are the traffic violations. These cost approximately $1,500 per case in taxpayer funds, equaling $28.8 million spent per year on failure to appear warrants. In my research with Pew Research Institute, Ideas 42, and the ACLU, we found that court notification and a text-based court notification system can reduce that by 72 to 90% overnight. What does that mean? That means that North Carolina can save $20.7 to $25.9 million in its first year of a text-based court notification system. When we're asking about where to find money, This is how, not relying on federal funds, this is how we start to unlock the door for jail-based competency, right? Or unlock the door for involuntary commitment and some of the other programs. Specifically, that money can be tied to, and I hope you all received the spreadsheet that I provided. There are 8 facilities in North Carolina right now owned by the state or local governments that can be converted to residential treatment facilities, that can be converted to housing, that can be converted to even, there's one jail that can be used if North Carolina chooses to move their sexual predators from prison to this specific special housing unit. It can be done. That cost is almost identical to what North Carolina would be saving with the text-based notification system. Again, not related to involuntary commitment, but it paves the way for how North Carolina can pay for this without having to go to the federal government. Talking a little bit about law enforcement assisted diversion. I've heard comments on crisis intervention teams, mobile crisis units. Crisis intervention teams are great. I will never speak poorly about law enforcement. They have an incredibly hard job to do. Did it myself. The job has progressed, much like community policing has evolved into problem-solving policing. Crisis intervention teams are evolving from crisis intervention teams to the use of mobile crisis units to now law enforcement assisted diversion. One of the problems that we saw in my research with Charleston PD, crisis intervention teams, their team specifically, they got trained, and then when I worked with them 4 years later, they had never been touched again. There was no retraining. There was no gauge on how well they were implementing their de-escalation techniques or doing the job that they were doing. They had moved to a mobile crisis unit. The problem with the mobile crisis unit, after hours, during hours, 9 to 5, they could get all the assistance that they wanted. Friday nights, Saturdays, Sundays, especially at the beginning of the month when people are getting SSI checks, tends to be a very active time for law enforcement. Mobile crisis units were down to 2 for all of Charleston County. And both of those individuals had to be on site in order for an assessment to be done. Law enforcement could not do anything. They could sit there and watch the person decompensate and continue to spiral and get more and more agitated while they waited for that psychiatric intake. They could not unlock the door themselves to get that person to a psychiatric facility as opposed to taking them to the jail. The result often was that they had to wait 3 or 4 hours. And by that point in time, the person had moved from being willing to go and get treatment to now being completely unwilling to get treatment and or actively combative with law enforcement, which brought new charges of battery on a law enforcement officer. It happened all the time. So there was a lot of frustration with mobile crisis units. I've been very fortunately blessed to work with law enforcement assisted diversion on the national level. And what we're talking about here is a co-response model. Again, I mentioned that I drove around with a mental health case manager, and it changed my mindset. I was, for Seminole County probation, I was the one who went out and served warrants. I was their door kicker. I loved what I did. I was not prepared to drive around with a mental health case manager, point blank. But my mindset changed. We began to speak the same language. Because of that, I went out and got whatever certifications I needed in order to be able to do the intakes. And in my off time from law enforcement, would go and work with the community mental health center to actually do these intakes. That becomes invaluable. I actually presented that same model to Charleston PD. Unfortunately, they weren't as supportive of it, except for when we started talking about female and minority officers. They saw a lot of need and a lot of utility for this, and it became a recruiting tool for them because they saw the service capability of this particular model. Again, not taking away from crisis intervention teams or mobile crisis units, but there is an evolution that has happened, and that evolution is law enforcement assisted diversion. I have been in contact with the federal appropriations for 2027 to make sure that federal money is going to where it needs to go for LEAD programs, not LEAD adjacent. The reason why LEAD is so good is because it's evidence-based. They have measurable outcomes. They have to report this. The states are involved. Local governments are involved. This is not something that happens with a lot of programs. And so the transparency that we talked about at the very beginning with data, that transparency and the cross connection between law enforcement and the treatment providers is ingrained in LEAD. This is why, in my opinion, it becomes the next progression of where CIT and mobile crisis units are. You also have halfway houses and therapeutic communities. I put up there the Other Side Academy. I don't know if anyone's ever had the opportunity to go out to Salt Lake City, Utah, and look at the Other Side Academy. It is an amazing organization. Typically, when we commit somebody for chronic addiction, it's 30 days. And then they come out and they go right back to using again because it's just enough to possibly, break bad habits. The Other Side Academy is a 30 to 36 month program. Understand that not only do you have to break the cycle of addiction, but you have to create those new habits. You have to get that person to change their mindset. And it is a voluntary program. Individuals have to apply to this. They come in, they graduate, they work. It is a self-sustaining program. Other than the initial startup money, and if I remember correctly, to start that program, it was about $1.4 million. They have never required any money from federal or state governments. They're completely self-sustaining. They have a donut shop, they have a moving company, they have a storage facility. They involve all of the people that are in the Other Side Academy into these business ventures. They then, once they graduate from the academy, they can move into the Other Side Village. Think tiny home villages, right? Each with little pods. They have treatment on site, behavioral health care, substance abuse treatment. They have medical care on site. They are also living and working in the community. This is what we're trying to get to. When we talk about an integrated setting, this is ultimately where we want to move. So it's not fully residential or fully community. It is supported. The spreadsheet that I provided for you with those facilities that can be converted into the Other Side Academy model would provide 610 beds. And that cost for a complete renovation in today's dollars is $26 million, roughly $26.1 million is what it would cost the state, spread over however long it takes to renovate those buildings. That was based off of your state and local or state and county registries of facilities that are currently abandoned. The spreadsheet gives you the date that they were abandoned, the current state of that facility, how many beds it can provide, and what it can do. If you did not get it, I would be happy to provide it to you again. So, building that continuum, AOT, assertive community treatment, is already built into North Carolina statute. Absolutely, it is absolutely necessary to be part of a robust involuntary commitment program in North Carolina. Again, this is not an either residential or community, it is a continuum. And I will tell you, and this is after working with the Department of Justice on what involuntary commitment can look like, we started to look at other countries and see what they did. Singapore had a great model. They have one building that houses all of their severely mentally ill, and then from there, they'll be released into different communities. Other countries have different models. When we talk about the number of people that would need to be committed in a residential facility, that number is actually very small. One of my peers that I work with is Dr. McCantscast. She was the former assistant director of SAMHSA. We both agree that the number of individuals that would need residential treatment is only about 10% of your severely mentally ill. The rest of them can move into this continuum of assisted outpatient treatment, assertive community treatment, halfway houses, and then into the full community. Again, focusing purely on severe mental illness and not behavioral health, anxiety, minor depression. Not taking anything away from that, but our focus on that has prevented us from looking at the problem of the severely mentally ill and the barriers that they have to any kind of treatment. Telehealth. The executive order, the governor's executive order, I believe it was Executive Order 33, focuses on telehealth. This is great for addiction and behavioral health needs. Someone who is schizophrenic, they're hallucinating, probably not going to take part in telehealth. And again, speaking from personal experience, that's just the reality of the population that we're dealing with and that we need to focus on. I've talked about long-term injectables. Your forensic assertive community treatment, this is where your probation and pretrial diversion officers come into play. I will tell you that initially there will be pushback from your probation department, just as there might be pushback from law enforcement. They're not going to see it as their job. It absolutely is their job. Their job is to get these individuals, when we talk about warm handoffs, and I've heard several of the presenters today talk about warm handoffs to community-based services, that is the probation officer or pretrial diversions officer to create that warm handoff and supervise it. I personally drove people to their first job, their AA meetings, their NA meetings, took them to their first apartment that they'd ever had. That is the job of the probation officer. That can be easily changed through policy, regulation, and statute here in North Carolina and the expectations of probation officers. And there are also ways to incentivize that. When probation officers go out and do the job that they're supposed to do and get the people the help that they need to, they should be rewarded for that. Doesn't necessarily mean that they get a check, but maybe they have a degree that they want to pursue. Maybe they want to present at a conference. They had an idea that they brought into place that they want to tell other states about. I personally did that after I wrote the program in Central Florida, and it expanded across to other counties in the state. This is how we reward probation officers for doing the job that they're supposed to be doing. And again, very simple change. Again, this means that the true continuum in North Carolina is achievable with what you already have. And frankly, it's of the states that I'm working in, and currently I'm working in North Carolina, Nebraska, Missouri, and New Mexico. North Carolina's got one of the most robust systems in place for statute. You have all the pieces there that you need. It's putting them together. Now we get into the fun part, the funding. What backs the funding? First off, you have Federal Executive Order 14321, which it was ending crime and disorder on America's streets. This addresses the impact of rampant homelessness, mental illness, and addiction. This has impacted Department of Justice funding, HUD funding, and SAMHSA. They are all now redirecting their funding and their notice of funding opportunities to support these programs. Federal Executive Order 14379, addressing addiction to the Great American Recovery Act, specifically directs DHHS and SAMHSA, again, through those grant applications and the notice of funding opportunities. Executive Order, this is North Carolina State Executive Order 33, outlined shortcomings in the mental health treatment and criminal justice capabilities and identified $213 million from the federal government for improvements. We talked about, now that executive order focuses specifically on crisis intervention teams. Again, not taking away from that, I would argue that LEAD is the better model and something that should be pursued a little bit more. You have high priority reentry programs for mentally ill prisoners. Absolutely agree, that continuity of care. This comes down to your certified community behavioral health centers. Certified community behavioral health centers can do jail-based competency. They create the bridge from incarceration and the treatment inside facilities to what's going on in the community. And they're also set up to do assisted outpatient treatment and assertive community treatment. Unfortunately, in North Carolina, there are two. There are two that have been stuck in the demonstration phase for about 5 years. They are SAMHSA funded. Why? The reason why is most of that money has been going to what's called federally qualified health centers, FQHCs. They focus on physical health and a little bit of the behavioral health. There are 43 in North Carolina with somewhere between 350 and 500 sites. They say that they provide mental health treatment, and they do to an extent, low-level mental health, behavioral health type problems. They do not address the severely mentally ill. This is where the certified community behavioral health centers come into play, and they have to come out of that demonstration phase, and they have to be supported and expanded across the state. They have mobile units that can work with law enforcement. They provide they provide the continuity from in facility to out of facility. They are a very important player in this model. HHS. Let me start off the HUD, Notice of Funding Opportunity Status. As you may or may not know, last year there was a change to Housing and Urban Development Notice of Funding Opportunity to incorporate treatment into housing. That was challenged successfully. However, the new NOFO is coming out, and it is making treatment mandatory for housing. to work together. It's not a housing first, it's not a treatment first, it's both of them together. This is much like what HUD and the VA have done in the HUD-VASH system. If I, as a veteran, need to get housing and treatment, I enter the HUD-VASH and I get treatment and housing at the same time. If I decide that I no longer want treatment, I don't want to partake in treatment, my housing could be in jeopardy. If I'm deemed by my treatment provider that I no longer need treatment, my housing stays. This is ultimately where I think the federal government is going to go, where they integrate treatment and housing more. HHS funding, the Section 1115 Institutions for Mental Disease Waivers, the IMD waivers, were extended for North Carolina. The new expiration date is December 9th, 2029. So those are those Medicaid waivers that, again, help support the CCBHCs that are provided through SAMHSA to provide that funding. Those 1115 waivers become very important, and they can be used until 2029. Again, that is backed by 2 federal executive orders and one state executive order. LEAD funding, I've talked about that. My work with appropriations, we expect to see that funding expand exponentially in 2027, specifically focusing on law enforcement. And I've mentioned the SAMHSA grants for certified community behavioral health centers to move them from the demonstration phase to the actual certified phase. This is something that has to be done. It has not, going all the way back to the very beginning of my presentation, because of the consent decrees from the Department of Justice on involuntary commitments, states were hesitant to really go after certifying these CCBHCs because they were afraid they were going to be sued, rightfully, by the Department of Justice. That has now changed. And so the funding that follows for these CCBHCs can make this a more robust system, and it's supported by SAMHSA. This comes with federal grant money. Last thing I want to talk about is the specialized courts. I know that there have been several movements for mental health courts, drug courts, veterans courts, and homelessness courts. I personally am not a fan of those. The reason why is you can have an individual, a vet, who can be in all 3 or all 4 of those courts, and they may not talk to each other. We've already heard about the communication problems with different agencies in the state. North Carolina is no different than any other state in that capacity. Combining those courts, which was actually recommended by the Conference of Chief Justices and the Conference of State Court Administrators back in, I believe it was 2010, both of those entities signed a referendum saying that these courts needed to be combined into one therapeutic system of justice. LA County did this. They took all of their specialty courts, they combined all of the administration, realized that there was a lot of redundancy that they didn't need. They took all of that money and pushed it down to the people actually doing the work. Now they could hire the social workers, they could hire the evaluators that they needed to do, and it's been met with a great deal of success in LA County. This is a model, again, supported by the Conference of Chief Justices and the Council of State Court Administrators to help create a more efficient system that actually talks to each other. Because now, much like LEAD, you have law enforcement providers and you have the treatment providers all in the same house talking to each other. Even if, for whatever reason, the systems can't talk to each other, they can compare notes. And with that, I welcome any questions.
Thank you, Dr. Sharp. Questions from members of the committee? Dr. Sharp, it looks like you have overwhelmed us with information. I appreciate your presentation. If we have second thoughts on questions, I bet we can send those to you through our staff.
Yes, sir. I'm at your disposal.
Okay. All right. Other comments from members of the committee? Representative Morey.
Thank you. Sir, are you working full-time in North Carolina?
No, ma'am, I'm not. I actually live in South Carolina, but our headquarters is in Austin, Texas.
Okay. I was a former judge. A lot of what you say I have serious concerns about. I mean, specialty courts, one of the last things you talked about. We have a variety of specialty courts in North Carolina, veterans, and it's all veterans, juvenile, it's juveniles, abuse, neglect, dependency. It's a very specialized population of peers that really help each other with the assistance of professionals.
Right.
And to combine these individual issues into one specialty court, I have a little bit of an issue with. We have a lot of what you talked about. We have law enforcement diversion, which they do an excellent job when they say, let's not arrest, let's take them to a mental health treatment facility, get the treatment they can do. And I think Disability Rights of North Carolina has fulfilled their mandate with the Olmstead Act. They want quality if people are in, residential treatment, not have solitary confinement in, juvenile facilities. And so I think they've really served their purpose well in North Carolina. So some of the things, I think were interesting, but some of the things from my experience, I don't see really fit with where we are in North Carolina.
So when I talk about the specialty courts, I want to be clear. I am not including the juvenile courts or courts regarding domestic violence or anything like that. I'm looking specifically at drug courts, mental health courts, veterans courts, and homelessness courts. Because specifically for homelessness, that's where we're seeing the concentration of severely mentally ill. Those 4 court systems is exactly what the Conference of Chief Justices and the Council of State Court Administrators focused on. The other courts, they absolutely serve a purpose. Juvenile courts, I've worked with South Carolina's Department of Juvenile Justice. I was on the Governor's Juvenile Justice Advisory Board. They absolutely serve a purpose. When we talk about severe mental illness, though, that does not show up typically in juvenile individuals. Schizophrenia, for instance, it shows up usually mid-20s, late 20s, across the board. And again, in my work with Dr. McCann's cats, these are late onset types of conditions. Major depression, yes, there are some precursors to that, and so there's a balancing act. Bipolar disorder, again, my stepfather is an example. His didn't manifest until he was in his 30s. So these are late onset types of conditions. But to your point, I do only advocate limiting those specialty courts of those 4, or combining those four specialty courts.
Representative Carson Smith.
Thank you, Mr. Chair. I think my hand went up at the same time as my great friend, Representative Morris, did. I'm going to take a little bit of the opposite side from what you said. I think some of the things you said today have been wonderful. This isn't a question, just a very short comment. I think Disability Rights of North Carolina has, maybe unintentionally, they have set us back. I think we have closed too many long-term beds down. We have pushed too many long-term folks who really need that long-term care out to the streets. So I would agree with you completely on that. And then once they get to the street, whether it be, I think you call it assisted outpatient treatment, we have our outpatient involuntary commitment that we don't use enough. It's actually keeping an eye on them and being sure they're doing what they should be doing from the courts, I think is a big thing. But I thank you. I think you brought some stuff here that's, I think, great for all of us to think about. Thank you.
Yeah, thank you.
Other questions or comments from members of the committee? Seeing none, Dr. Sharp, thank you again. And the committee is adjourned.